Assalamu alaikum. Good morning, everyone. Welcome to the second day of Patient Safety Symposium. A gentle reminder, please, to visit the poster site and vote. Closing time is today midday. We have many interesting sessions today. We will begin with some opening remarks from Dr. Saeed Al-Yami, Chief Quality and Patient Safety Officer at JHAH. Please join me in welcoming Dr. Saeed Al-Yami.
Good morning. Welcome again for our next day. Yesterday was a very challenging day. You know, the first virtual for more than 1,250 registrants. So there was a little bit of technical issue, but the good news that we managed 99%. 1% will be fixed by sending the missing part of slides, which was most likely in preparation, and they will do it today. We'll have a lot of good speakers today. We are managing our technical issue. Before I start, I want just to acknowledge, because usually I forget at the end, either I'm getting older or it's part of me, is there is a lot of great team that first of all coping with me, and I'm a difficult man to cope with sometimes, is my team from Quality and Patient Safety, whether Rose, Rabab, Martin, and the rest of the group, and also Tagreed. So thank you for doing the right thing. And Mr. Kohaji is there. He's a guy, I've been calling him more than my wife in the last 24 hours. So, and he's doing a good job. So continue the good thing you do. I really appreciate it. And it's normal, you know, when things go a little bit glitchy, we want perfection. And I know that you are doing a great job. So thank you for the thing you are doing. With that today is our second and last, as you know. There will be some poster evaluations. Please do it. It's important to have more vote, to have more, more objective assessment for the posters. We'll have an external speaker, our internal speaker. We are great people waiting in line to give their talk. And we'll end up today with, I think, our speaker from JHAH. There will be our CEO will join us today, most likely for the presentation and closing remark. With this, I think I'll give it to Sharif to introduce our next speaker. Thank you very much and have a pleasant day.
Good morning, ladies and gentlemen. Now the first session of our conference is, I'm pleased actually to introduce Dr. JHAH Al-Qahtani, Director for Quality and Patient Safety in Imam Abdul Rahman bin Faisal Hospital at National Guard of Health Affairs. The title of Dr. Al-Qahtani presentation is Patient Flow. Please join me in welcoming Dr. JHAH.
Assalamu alaikum.
I'm Dr. JHAH. We hear you very well. Go ahead.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum jami'an. Good morning, everyone. Thank you for the Dr. Saeed, for Dr. Sharif, for the organizing committee, for the audience, for having me today, and for being part of this patient safety symposium. My talk today is regarding patient flow. In our hospital, we conducting quality and patient safety hospital-wide project from year to year. Then in the end of 2017, we were thinking about what kind of project we will have. So we study our patient safety survey, patient safety complaint, report, then we found a lot of things that should be improved related to the patient flow. We link this to the different M&M, departmental morbidity, mortality, hospital M&M, and safety reporting system, which is the OVR, and we decide to have patient flow as one of the hospital-wide project in Imam Abdul Rahman bin Faisal Hospital, which is one of the Ministry National Guard Health Affairs facility. So as you know, that optimization of patient flow need different approach and need capability and capacity for improvement. So if you stop any patient, then you ask him, what is the main problem? What is your concern regarding any organization that you visit, healthcare setting? So he will talk about the access to care. And by the definition of IOM, timely use of personal health service to achieve the best health outcome. And when you review the component of the access to care, beside the services, coverage, and workforces, the timelines. Timeline is one of the important components for the access to care, which is the time patient spend waiting in a doctor office and the ED. So what is the patient flow? In general, it's a critical component of process management in the hospital and the other healthcare facility. It's a movement of patient through a healthcare facility. It's involved the medical care, physical resource, and internal system need to get patient from the point of admission to the point of discharge while maintain quality and patient provider satisfaction. Optimization flow, it's like solving a puzzles. And when we go through the project and we see the different study that I bring, that you will see how sometimes difficult to cope and to reach to your target. It's combined with different strategy and process to engage all team members in finding the best plan. The result of efficient operation that's conducted to improve the clinical outcome, positive patient experience, and physician satisfaction, and improve the safety, and eventually reduction in the care cost. When we see the cost per patient paid hours, we determine that to be $58 in the ER and $24 in inpatient in floor. So while we focus inpatient flow, ED become crowded, stressful, and unsafe. Patients are admitted to outliers to the ward and are not best suited to manage their care, and it's very important for a patient. It's patient concern nowadays. Ambulatory care service and the clinical decision unit, even catheter lab and other endoscopy unit may fill with the patient. Inpatients are shuffled between ward to make rooms of newcomer. Staff are overstretched and routine activities slow down dramatically. Clinical outcome are major worse, particularly for weak people and who suffer from harm even and may be conditioned due to the extended period in the hospital and exposed to hospital-acquired infection, to the fall, and other risks that in the hospital when they stay more than they needed in the hospital. Patient and healthcare work time is wasted due to delay and slow care process and their experience in adversely affected. So JHAH papers, they come with 10 tips to improve the patient flow. Align reporting with your department head, create a culture accountability, gain executive support for improvement patient flow, explore different staffing model, use technology to improve patient care and safety, and install the patient flow standard for boarding time 4 hours, providing an automated bed board tools for the vacant beds in the hospital, train staff on time management, invest in mobile technology, and trying to maintain and operation to the patient experience and utilize the advanced data analytics. So the impact of all those efforts that with the patient and optimization of the patient flow will make delivering the right care in the right place on the right time as a strategy priority, leverage hospital-wide patient flow initiative to improve the patient safety, patient experience, and the clinical staff satisfaction, align medical staff and hospital executive to achieve the improved flow, adopt value-based care or value-based payment model to support the improved flow, especially when talking about the readmission or early discharge, etc. Demonstrate that improved flow has a positive return on the investment and connect the work department and utilize the hospital-wide flow strategies. Studies in different organizations show that the prolonged waiting time result in decreasing the quality of care, higher morbidity and mortality, decreasing patient satisfaction, patient and staff satisfaction, actually increase the cost of care ambulance diversion, higher number of patients who leave without being seen, and you will see one of our slides what we have from data from Imam Abdurrahman bin Faisal Hospital and length of stay. So here different variables for this study show pre and post implementation of some intervention that they adopt, and their aim was to increase the the hospital admission and to be in the frame with 60 minutes. And there is some improvement they got from different variable. But you just notice that they spend 3 years um, in the intervention. This is give you a hint about how complex is such project and initiative when you implement it in the hospital. It's like the OR utilization and other hospital-wide project. So it's gonna take years. Maybe you cannot reach to your target from first cycle, second cycle, third cycle. Try to restudy the measures, restudy the intervention until you reach to your target and satisfy your patient. So in Imam Abdurrahman, we start in 2017, and we have the first cycle in 2018 and 2019, and the second cycle for improvement was 2020. So we start by studying our survey. As I mentioned earlier, there was waiting time duration before the patient seen in the outpatient was 22.7. They were not satisfied about the waiting time. In emergency, 38.6. So our decision based on this data, and it was one of the leadership concern to start this as hospital-wide project. So we start to draw the process measures starting from ER, inpatient, and outpatient from registration until discharge the patient from either ER or from inpatient and from outpatient. We will go through this in detail. So our goals was improve the communication with the committee formation and standardize the guideline, increase the patient throughput and number of patients seen, increase the patient satisfaction. So our goals in National Guard, it was one of our goals, it's a highest quality care within the resource. So it's about efficiently improving the patient experience and care outcome. We start to have the team, and I need to emphasize on this, the team should be multidisciplinary because it's business for everyone. It's not only quality department. Everyone should share on this. So we have multidisciplinary team and different input and different brainstorming and intervention from different departments and different stakeholders. We try to study the process. So we measure our baseline, then we think about the benchmark, internal and external. Actually, we cannot find, apart from ER that we use the Canadian triage, we cannot find something in the study or internal with the, with other region of National Guard that the data that can support our patient flow. So we decide to have 10% reduction in time from each process. So you see our baseline is going up more than the target that we put. Then we start by emergency department, and we saw that our data show that we are above the target in different measures that we select. Then we adopt CTAS Canadian triage in the ER, like most of the organization. Then we put our data in the dashboard. Then we see that we have problem with the CTAS level 3 and CTAS level 4. People, we are more than the target, and patients stay more time. So we have the fishbone, and the fishbone is different between about dashboard, about staff shortage, about lack of reference, and patient acuity. So where are the bottleneck? I have to run on this one. They told me 10 minutes, and they have a lot of slides. So overstay in the ER due to the shortage, admission from all area, delay, physician referral, consultation, inconsistent with order and referral, unavailability of valid measures. In inpatient as well, we have 2 measures above or 3 measures above the target, and we study the fishbone again, most probably same finding, same root cause we have. Add to that, pharmacy process is too long. So we study this, and we found delay in discharge, patient factors as well, transportation for patients when they decide to discharge, unplanned consultation, update discharge medication, and availability of valid measures in the dashboard. Outpatient as well, all the measures were unsatisfactory. So we study it again. We study it, and we look for the root cause for this one. We found the main causes are the physician accountability consultant don't attend in the clinic on time, so the resident hesitant to discharge the patient and waiting or call for the consultant to take the decision. Patient walk-in, overbooking, and availability of DASH measures in the dashboard as well. So our goals was to increase satisfaction by 90% and decrease 10% reduction in each step or each process. So we start the first BDCA cycle. This is the dashboard that we draw and we implement in our hospital. And we start by planning ER, create patient flow dashboard, develop the KPI, improve the patient discharge process, and allocate physician to the level 4 or 5 in the decreasing the number of waiting time. In inpatient, we improve the discharge planning. We ask the consultant to be rounded before 9 a.m. and stream the communication between the hospital department and the other specialty and the pharmacy as well. So in the outpatient, we start the compliance with the starting time by 8 and 12:30. We create walk-in patient guideline, create overbooking guideline, and nursing, we study the nursing staffing. So we check the result for the first. There is very good outcome, especially in the outpatient. Still, we have difficulties in the ER, especially from triage to seen by doctor, and from the inpatient, we still have, there is some improvement. We can consider this very good outcome, especially for the primary outcome. I will just show you now, but still for the other outcomes or the other variable, we still to work on it by studying the measures and studying the intervention. So we have some improvement in the emergency. You see CTAS level, we solve the problem. Still we have in the level 3 point patient acuity still problem. Inpatient, we have some improvement. We are below the target still for some measures. It's not same in the outpatient. So let's go to the patient satisfaction survey. We did a survey for 2018-19. We see dramatic change, and people, they are more satisfied than when we start the project, and this is very good outcome, primary outcome for us. The patient are satisfied. We don't reach to the target 10%, but this is very good movement. Same for outpatient, we have very good improvement. So we go to the second cycle. We start by the last 2 months and the first 2 months of 2021, because in the COVID we cannot do this project. You know, there is a lot of factors that we cannot study the waiting time for this period. So we start by the last 4 months. Our aim to enhance the level of satisfaction, to improve the communication, enhance the accuracy of patient flow, and to reduce the patient flow waiting time. So we go back, we see the satisfaction is a little bit high, and we can understand this. It's justified by what we have in Corona and all the other factors that, you know, it's global. And for OPD as well, there is some increasing in the dissatisfaction from patients, especially in level 3. We will see the result. Then we go to the emergency. Then we study the measures. In such project, you have to go and study the measures again and again in order to reach to the root cause and the right intervention. By studying the ER patient, we see the ER physician were not utilizing the icon in the best care that seen by doctor. So it was only small portion, 1.7 compliance, which is very low sample size. It cannot reflect the reality. So we go to the patient seen by physician. We ask the physician to emphasize to use this icon in order to know the right time of seen by physician in ER. Then we study the data again, and we found that we still have some problem, and there is a room for improvement, especially when patient is finish the triage and until to seen by doctors. Still we have problem in the CTAS 3, so we need to work on that. Then we study how much is the discharge from ER and the other specialty to see where is our emphasis. Then we see that the ER physician is the most physician that they discharge patient. We study the boarding time. One of the things, it's people, they're looking for the boarding time, and it's one of the JHAH improvement tips. So we don't have real problem. It's only 7%. We don't have any problem in the boarding time. We go to lift without being seen in the last 4 months. We have problem. We have 18 patients leave the organization without being seen. And for the other, it's 620. They don't register. And this is, we have to focus on this one and looking for maybe our patient has high expectation in that. So difficulty in ER was physician not utilize the correct icon. Physician are seeing level 4 or 5. They are focusing on corona before level 3. And non-emergency cases, follow-up dressing, and the other following instead of BHC or BD, they come to the ER, and day access are instructed to visit the ER for admission. So we decide to decrease the level by 10% and increase patient satisfaction by 90%. In second cycle in ER, we ensure that time seen by physician is completed by ER physician, prioritize level 3, and to ensure the CTAS level classification is done correctly. We try to emphasize on the CT scan and the other radiology modality that it's sometimes patient came 4 a.m. They are waiting 4 hours until the consultant come in the morning. So we need the service 24 hours. And for the non-emergency should be instructed to go to the outpatient or BHC. In inpatient, we study the data again. We found that there is 6 hours and 46, but there is 5 hours. Don't understand where this spend this 4 hours. Then we study the data. We again. And we found that we need to have the measures and correct the measures that we add the actual time of discharging of the patient. So this is the data again. So the difficulties was in the discharge medication unstructured are not given to the patient within the time frame from a nursing physician. Some physicians are instructed the nursing staff to hold the patient. We found that same day admission, they keep the patient. So we have to take it from our denominator. Improper early discharge planning for multidisciplinary staffing. We have staffing problems and the staffing nursing are shortage in the inpatient. Patient factor about transportation and about education to go early. So we study the pharmacy part from discharging order until verification, and we still have problem in this. We found we spent 59 minutes from discharging order until verification by pharmacist. When we asked the pharmacy what was the problem, what is the main, they said the order is not clear, prescribed drug-drug interaction, medication updated, incomplete order due to improper reconciliation and no response from physician. Sometimes they page the physician 2 or 3 times, they don't response. Other time is regarding the discharge order are not inpatient pharmacist first priority. They don't have specific pharmacists to discharge the patient. They are responsible for other inpatient and stat order. So we decide for inpatient to decrease the medication order to be received by nurse by 25% and decrease the time from receiving by nursing to actual discharge by 50 times and increase the satisfaction as a primary outcome. So we assign overseas discharge from nursing, pharmacist, physician. We standardize the nursing practice regarding the discharge. We stick our staff and adhere to our ABB by 24 hour earlier discharge. And we try to exclude the same day admission from our equation. And we include inpatient satisfaction. When we study the patient satisfaction survey, inpatient satisfaction survey related to the discharge was not there. We will add it as one of the dominant there. Outpatient, finally, we're talking about the outpatient. Outpatient, by studying the data, the team was to improve the time from seeing by screening to seeing by doctor. It was not noticed that the seeing by doctor is measured when the doctor save his or her progress note, which is sometimes it doesn't reflect the correct time. Different physician, different practice, they don't save the time. It's not real safe seeing by doctor. So we ask the nurse, we add this task to the nurse that when the patient get inside the clinic by nursing note, they should write the time. So we study the time again and to be sure where is our problem. We see that our problem mainly it's between screening and seen by doctor after we changing the measures. So and still there is 2-3 minutes for improvement inside the physician room. So difficulty in OPD was consultant that does not attend on the time, patient walk-in, medication refill, request lab result, ask for medication report, request for referral, and overbooking as a system and unable to measure the accurate time is one of our main problems. So our aim was to reduce the OPD waiting time by 20% and increase the primary outcome, our satisfaction for patient by 90%. So our strategy was to compliance with the starting time, 8 in the morning, 12:30, the PM clinic. Clinical should be start by consultant, reduce the number of walk-in from 10 to 3 patients per clinic as needed, and reduce the number of overbooking. The physician has the function and the privilege to put 10 patients, so we will decrease it to 3 patients only, and reduce and improve the dashboard and establish a market for medication refill for the major subspecialty of family medicine, pediatric and internal medicine and surgery. So our action plan, this is the last slide, is 3-month data will be collected to study the effectiveness on the intervention. Each service, ER, inpatient, outpatient, will be responsible to implement the agreed action plan. Quality department will be responsible to monitor the compliance of the process, and ICE-ID or the IT will validate and improve the dashboard. So in conclusion, I think admitting, treating, and discharging patient minutes and hour a matter. So optimization, so the optimization of the flow will be definitely impact on patient and staff satisfaction and patient safety, and eventually in the cost reduction in the organization. Thank you. Thank you. You hearing me?
Okay, thank you, Dr. JHAH, for the wonderful presentation. Actually, we still have time for your session up to 10:40, but in my panel, actually, I don't have any questions from the audience. I'm not sure of any question for the main auditorium, so please go ahead. I get one question for you, Dr. JHAH, if you allow me.
Yes, please.
One of the audience is asking, was the changes implemented sustainable? I mean, maybe he's concerning about the patient satisfaction target in your project.
Thank you for this question. It's an excellent question. When you see the last slide, I said the quality and the ICE-ID or IT, they should monitor the process. And we agreed as a committee to have monthly meeting, because sometimes there is a special causes. It's come and you need to eliminate it and mitigate it before it's be a problem in your data. So we agreed a monthly basis to have this meeting. But from the first cycle, there was some sustain and we hold some gains. But actually, when the corona come, especially in the ER department, we have problem, and our primary, as you saw the last slide, that our primary outcome, which is patient satisfaction, goes up because of that, because we concentrated some time on the corona patient than the other patient. But I think there should be monthly meeting for the committee and for the task force or the committee for patient flow, and they will study the data and they try to mitigate all those obstacles in order to improve the patient flow and to have the good outcome.
Next
Thank
question.
you, Dr. JHAH. There is one more question from the main auditorium, so please go ahead.
The changes that you made in your institute regarding better utilization, did it require spending more money? And the second question is that, do you think that whatever you are going to do changes is going to increase the burnout of the physician, to satisfy the patients?
I think it's a very good question again. Regarding the money, it's different from different organizations. I cannot speak in behalf of the others organization, different hospital, different setting. But actually, you need to invest some money, yes, of course. And as I mentioned in the early of the presentation, it's the investment of this project, eventually it's cost reduction. As I mentioned, there is when we're talking in the ER, $58 per hours patient stay for nothing, and in $24 other in inpatient floor. Investing in this in the beginning, it will be impact on the resource and impact on the reduction of money in the end of the day. But you need some investment, yes, it's depend on the organization. For my hospital, we have very good IT people and ISID people. We have very good structure, so our investment was not that much during the patient flow. The other question regarding the burning, as one of our variable and outcome that we look for is the internal and external customer satisfaction. So just believe me, when you have the patient and discharge in proper way and in the right way, and you will not have him after 72 hours in your ER, this will decrease the physician effort and physician time and the resource, etc. Same for when you have a patient stay in your floor for example, hours or sometimes days without proper discharge, and patient goes through fall or hospital-acquired infection, then stay in your hospital more effort and more burning for physician. So no, I think you have to balance between the patient satisfaction and the physician satisfaction.
I guess one more question, and at the main auditorium, please go ahead.
Yeah, thank you very much, Shahar. This is a great presentation, and it's a great effort. I have to commend you on that. My question is about the patient satisfaction. In the slides you displayed, you were displaying the dissatisfaction. And this leads me to the question on how you measure your satisfaction. The first question is, do you use the Press-Gurney survey? The second one is, if it is an internal one, an internal kind of survey, do you ask you questions in a way that reflect the dissatisfaction rather than the satisfaction?
Okay, thank you for the question. Press-Gurney, we don't use it in our hospital. It was one of our thoughts, but we didn't use it. We use hospital-made. It's not hospital-made. It's among National Guard hospital, and it's monthly. It's questionnaire that has been made in the corporate, and it's reflecting different domain. It's not about waiting time. There is a lot of domain. I just bring in the beginning just related to the things that link to the patient flow. And no, we measure satisfaction and we measure unsatisfaction, and we have 3-4 level of satisfaction. We measure it, but I just bring the conclusion here as the unsatisfaction. No, we measure the others, and you are right. Sometimes you don't go to the unsatisfaction only. Some people that they are neutral. Even for the neutral, you have to include them. But it's the main concern for our hospital. When we categorize the domains of the patient satisfaction survey, we found that the waiting time is one of our patient concern. That's why we translate those data to hospital-wide project. Thank you for your question.
Thank you, Dr. Shahar. I think I have another question, but you already answered this question, because one of the audience is asking again, can we know the benchmarks for the outpatient satisfaction surveys as per your project? Thanks.
Yes, I think I did answer this question, and I hope that in the future that we have benchmark with the Eastern Province Hospital. Now people, they are doing benchmarking with the regional hospital, like your hospital or the other hospital, with this data, and we just share the experience and knowledge as well.
Thank you, Dr. Shahar. So I think we reached the end of Dr. Shahar's session. It was really a wonderful and fruitful presentation. I can't thank you enough, Dr. Shahar, for having you with us today during this symposium. So at this moment, I'm gonna leave you, and we're gonna go to the next speaker, who is Dr. Muazzam Zaidi. He is Johns Hopkins Aramco Healthcare Occupational Medicine Specialist. Today, Dr. Zaidi will be discussing making JHAH a safer place to work, importance of reporting occupational injuries. Please join me in welcoming Dr. Zaidi.
بسم الله الرحمن الرحيم نعمته ونصلي على رسوله الكريم. Assalamu alaikum. Good morning to all of you. Hope you're enjoying the symposium. Today, I'll thank the organizers, Dr. Yami and his team in Patient Safety, for organizing such a wonderful conference. Most of the time, most of the adults in their awakened life would spend at work. Hence, it is essential to keep the workplace safe. Today, I'll be talking about the importance of occupational reporting in keeping the workplace safe. While during the presentation, I will outline the department to which I'm working. We will also touch base on the definition of occupational injuries, accidents and injuries, and then try to understand why reporting is important. We will touch base on DATEX, which is the reporting portal at JHAH for occupational injuries, and review the 4 years of data of occupational injuries we have at our organization, concluding with our future initiative. I feel privileged working at Johns Hopkins Aramco Health and being a team member of a department which is endeavoring to keep the workplace safe and healthier. I hope most of you know the department. It has 2 units, Occupational Compliance Unit and the Occupational Health Unit. Our team is led by Dr. Tayyar and Dr. Muhammad. Most of our clinicians are trained abroad, and we bring a wealth of knowledge of best practices from different parts of the world and encompass them in trying to make the workplace safer. If you would see the units, we have the Occupational Health Unit, which looks after the health and well-being of the clients in case of a pre-employment, after an injury, return to work, and we investigate every occupational injury to ensure that our staff members and the patients are safe and they're healthier and well prepared to return to work. The Environmental Compliance Unit, on the other hand, is responsible of the proactive and reactive effects, like keeping the workplace safe, ensuring radiation protection, and ensuring that the environment of our workplace is safe and is at the best possible standards. Our team is led by Mr. Al-Shahri, the Chief Operating Officer, and we have the privilege of him being a great advocate for occupational health reporting. He has encouraged the contractor reporting and has encouraged to bring occupational reporting to the forefront. Starting at the reporting system, we just have to understand what is an occupational accident. Any unexpected, unplanned occurrence, including acts of violence arising out or in connection with the workplace, resulting in a harm to the worker, which could lead to an injury, a disease, or death, or an occupational accident. Hence, what we're saying in this definition of International Labour Organization is, if you're at work, any activity which leads to harm is an occupational injury or an accident. On occupational injuries, reporting of occupational injuries is pretty good. And we see that the flow of occupational injury and accident reporting through DATEX has been very positive, and we'll be discussing the data soon. But the aspect of occupational diseases is very important, and I'd like to focus on that for a few minutes. Occupational disease is illness which is contracted due or in process of your work. It could be while coming to work, it could be of an overexposure to asbestos, silica causing asbestosis or silicosis, or in a healthcare setting, it could be an infectious exposure. Infectious exposure could be towards tuberculosis or COVID. I would, at this moment, try to bring in focus the excellent ability of our team. I would encourage and recognize the efforts of the task force, the infection control team, along with the members, every member of the JHAH, which has made a tremendous effort in ensuring that not a single occupational exposure has led to a COVID. This is a great achievement in itself. From the last 12 months, our data shows that not a single occupational exposure led to COVID and or COVID-related admission. I would want everybody on the floor of JHAH to take a moment to recognize themselves, because it is essential to appreciate our successes, and especially when the frontline workers were working tremendous hours in emergency, in primary health care, in all locations, and they had adhered to the best practices and stick to the standards, so they kept themselves, the patients, and the family safe. So a moment to appreciate. Why is appreciating important? Giving credit to ourselves is essential to enrich the experience, to encourage ourselves in the future to follow it, and in pleasure and credit to our team encourages and ensures its well-being. And to have a wonderful system which works, a hospital which is in tuned to focus to giving best healthcare, we need the best of our workers. We need our staff to be in the best emotional and health status to do that. Why is reporting essential? I'll share these two pyramids. Mr. Henrik, in 1930s, studied 75,000 injuries. And when he was studying these injuries, he found that there was a flow. There was a constant theme which came across, and that theme was that there was a number of accidents which were prior to us having a minor event, then a major incident. It was his formulation of this data that he felt that if we could stop the minor injuries, we would be able to prevent the major accidents. And hence, if the pyramid's base could be squeezed, we would be able to reduce accidents and injuries of more significant nature. The same data was then assessed in 1966 by Mr. Frank Bird, and Frank came to the same conclusion. He felt that there are unsafe acts, which lead to near misses. The near misses then to minor accidents, then to major. And if you see that we see after decades a very similar number of events. And hence the focus is that if we can prevent the near misses and unsafe act, we can prevent the danger or the significant events. How can we prevent an unsafe act or a near miss? That's a question, right? It won't be a very interactive session, but the only way to prevent an unsafe act or a near miss is to acknowledge it. Hence, reporting is essential. Reporting is not just putting time in and telling what happened. It is the first step of prevention. If you report a near miss or an unsafe event, it is going to be analyzed, a root cause analysis would be done, and in future, the event would be prevented. More than likely, you were lucky not to get injured, but to save a colleague, I encourage you to report. In Johns Hopkins Aramco Healthcare, we have a very user-friendly system to report. We're using Datex since December 2016. Datex has shown to be an excellent tool, a portal to not only report accidents and events, you can report the near misses, you can report events which you feel could be improved. And why? As I said, that if we report the event, we have the ability for the other teams to go and investigate in it and to see how we can improve further on it. Datex also gives us the ability to analyze the trends, and I'll be discussing the trends which it shows for the last 4 years. And then not just to analyze the trend, it helps us to see how we have put in the preventive measures, because that would be shown on a reduce of future events of a similar nature. And at the end of the slide, we have the email address if there is any questions regarding to Datex. I'm sure that all of us are familiar with Datex, but if you are not familiar with Datex, I would encourage you to familiarize yourself, because this one tool can help you make JHAH a safer place. We did a retrospective study of our occupational reported injuries through Datex from 2017 up to 2020. And what we found was that 50% or more annually of our occupational injuries were related to blood and body fluid exposure. Not a surprise, most of the health facilities around the world have a similar statistics that blood and body fluid exposure, which include human bites, mucosal exposure, and needle stick injuries, are the bulk of occupational injuries. In addition, our second highest was slip, trips, and falls, and I'll touch more base on it in the future slides. The slide gives you a better appreciation of if we keep all the injuries, else the blood and body fluid exposure, they're less in amount, in quantity, than the blood and body fluid exposures. But which one of them would have a more impact on reportable injuries or days off work or our staff's incapacity? A question just to keep in mind. We'll touch base on it in a few different slides, but it would be nice if you could answer that at yourself. Which level, which one do you think is more reportable injuries, or which one would have led to more time off work? Blood and body fluid exposures or slip, trips, and falls? I would share a story with you regarding reporting at this stage. And it's not from our hospital, it's from one of the hospitals I've previously worked in, and the story has been modified slightly. There was an EMS consultant working hard on last evening before his annual leave, and there was a road traffic accident. He's stitching and gets pricked. He's in a hurry, it's the last hour of work, and he needs to go off. He leaves. On the same patient, we see what happens is that a registered nurse gets a needle prick while maintaining the IV line. The nurse reports the event, blood is taken from the source, and he's found to be HIV positive and hepatitis B positive. What happens? Immediately, the nurse's blood work is done. She has immunity to hepatitis B. HIV prophylaxis is started within 24 hours. And if HIV prophylaxis is started within 24 hours, the success rate is more than 97%. The nurse is on the protocol prophylaxis. The physician returns after a week. While talking to her colleague, she says that she's not feeling well because she's on the prophylaxis. He asks, but why? And she says, oh, you remember the last shift we were on? I got a needle stick injury from that patient. He was HIV and hepatitis B positive. He says, what? It's a shock, right? A moment of truth. He said, no, but I also got pricked on that patient. She said, did you report it? He didn't. He came to our office immediately. Bloods were taken. He didn't have immunity for hepatitis B. And the window of us providing them care was 72 hours. It has lapsed. So giving him immune bodies wouldn't help. And the window to start a prophylactic treatment for HIV had lapsed. And in my room, at that moment, he sat absolutely quiet for a few minutes. And in our future conversations, till the 6th month had passed, and he was sure that he did not have seroconversion to HIV, he was emotionally shocked, traumatized. And one thing which I remember him telling me is that I do not forgive myself for not reporting, because I had the chance of preventing this, and I didn't take it. Unfortunately, he seroconverted to hepatitis B, but fortunately, he did not seroconvert to HIV. If you report, we have prophylactic treatment which could save you, but it all depends. You've got a choice, and the choice is, would you like to report or not? And that one decision can make a big difference in your life. A prick is just not a simple prick. I hope that the message is going across how important reporting is. And with our present leadership of our CEO, Mr. Cherry, we've tried to encourage not just our staff, but also the contractors, the subcontractors to report. Because once you're on the premises of JHAH, your safety is our responsibility. And building a safe community is the only way to keep us all safe. As we would see that our data shows that operation room was the highest in the needle stick injuries. We tried to benchmark our numbers with international numbers, and we see that John Hopkins Aramco Healthcare had 7 blood and body fluid exposures per 100 beds on average over the last 4 years, which was in line to some of the studies from Japan by Yoshikawa, who's reported 4.8, although Kunishima in 2019 reported it to be in a variable between 12 and 36, so it was a little less in number than that one. Slip, trip, and falls, which were the second major cause of our occupational injuries, were 13.45%. And when I was trying to benchmark it with international studies, we saw that NIOSH reports that healthcare providers have a 90 times greater risk of fall. And there was a number of reasons for it, some being unexpected events, crowded emergency rooms, and sometimes it could be as simple as some shoes on the floor, and while moving or turning, a staff member gets tripped, and which has resulted in a fracture over the last few years. We've been using a Saudi taxonomy for our occupational injuries, and that ensures that our data in the future will be comparable to national standards, and we will be able to compare our efforts for preventing injuries with our national colleagues. Reportable injuries. Our department has been reporting lost time injury, medical treatment, and restricted injuries on a regular basis. And we can see that there has been a steady trend, except in 2019, where the number of lost time injuries was higher. In most of them, what do you think? My first question, were they from blood and body fluid exposures or slip, trips, and falls? It was from slip, trips, and falls. It seems very simple. It seems like it wouldn't happen, but when it happens, it leads to an injury which then can require time off work for prolonged duration. I'd conclude with that our lessons learned are that if we can focus on reporting, encourage reporting, we would be able to see that if there are reporting systems better, we could be able to do the root cause analysis and prevent them from happening in future. Some of the reasons of low reporting could be that our preventive measures are working. We have a culture of safety, and our engineering controls, including retractable needles and using staplers at the surgery, has worked. Our future counter initiatives would be encouraging staff to properly report, encouraging subcontractors to report. I would encourage you that if you see a contractor being exposed, injured, slip, or a cut, or even exposed to dust more than it should be, let him report it on Datex to his supervisor. And just to conclude on that, it's a joint responsibility. And when you take the first step of reporting, you ensure that we are making JHAH a safer place where safety of our staff, patient, and our families come first. Thank you so much. Thanks for the opportunity to be here.
Thank you very much, Dr. Zaidi. Very nice journey through occupational safety. From my panel here, I don't have any question from our audience. If there is any question in the main auditorium, please go ahead.
Thank you.
So it's time to close Dr. Zaidi's session. Thank you for your listening so far, and I hope you are enjoying the symposium so far. Our next session is titled Nursing Experience at Johns Hopkins Aramco Healthcare during the 2020 COVID-19 pandemic, which will be delivered by Ms. Mariam Abu Hlega and Mr. Islam Toot, Ms. Zainab Maher, and Ms. Maysa Rab'an from JHAH Nursing Department. Please join me in welcoming them. Thank you.
Okay. Good afternoon. So 2020 was deemed the year of the nurse and the midwife. Nurses across all tiers of healthcare around the world bore the brunt of the pandemic. The nurses in JHAH have displayed the highest level of professionalism and competency during this pandemic response. I know that 30 minutes is just too short to highlight a year's worth of nursing excellence and achievements, but my colleagues and I will try to show the nursing organization contribution to the COVID-19 pandemic to the best of our abilities. This presentation is on behalf of JHAH nurses and dedicated to JHAH nurses. We will try to cover our mass and 95 fit testing and training. We'll go over our visual triage stations. We'll touch briefly on PCR swabbing and nurse-led support services, training and staff preparation, quarantine facilities, and home monitoring program, and we'll conclude with a patient perspective. Although JHAH had a structured respiratory protection program, we didn't want to take any chances with the safety of our frontline staff. Clinical Practice Education and Research Department, which is part of the nursing department, in collaboration with Infection Control and Industrial Hygiene, have conducted a massive campaign to fit and refit direct care staff. During 2020, 2,471 direct care staff were fitted to respirators, and the majority of those were during the first 2 years of 2020 before the WHO have declared COVID-19 to be a pandemic. It is worth noting that in the first 2 months of the year, we have exceeded our typical annual testing numbers, so kudos to everyone who was involved. Moving on to our visual triage, I know that a number of my colleagues have touched base on this on the number of presentations yesterday, but I want to highlight the nursing side of things. Visual triage, although is a very simple concept that involves screening everyone who walks into the facility for symptoms suggestive of COVID-19, there's a lot of work that goes on behind the scenes to ensure that these stations, that every entrance in Dhahran Health Center and in the district is staffed 24/7. Scheduling of nursing staff and nursing assistants required a lot of effort, and that was done on additional work basis. We have seen many nurse managers, nurse educators, and shift coordinators step up and fill in during breaks and whenever someone calls in sick. In addition to ensuring that all these visual triage stations have the necessary equipment for them to do their job properly, from provision of hand sanitizers, masks, to batteries for the thermometers, which was taken care of very well by the nursing department. Switching gears to PCR swabbing, which will be elaborated on by my colleague Islam, which I'll hand over to now.
Good morning, everyone. We're so glad to be with you today. PCR swabbing was one of the turning points in responding to pandemic, as you know, not only in JHAH, but all over the world. We started doing tens of swabs per day, but the demand rapidly increased the following weeks to accept hundreds of swabs per day. This is a drive-through swabbing, one of the stations that we have started in JHAH to accommodate the increased demand of PCR swabbing in Dhahran and districts. The demand was extremely high day by day, responding to the number of contacts and travelers who are arriving from overseas and who are supposed to be swabbed. This is a streamlined process launched in March 2020, last year at Building 50 and districts, allowing healthcare professionals to swiftly test identified candidates while they are seated in their in their cars. So this was actually a challenging situation where we have to provide the best possible experience for the candidates who are coming through, at the same time maintaining zero errors and zero mistakes. In this slide, you are going to see the numbers of swabs that have been completed only in Dhahran through drive-through and other stations. As you can see here, on April 20, we started with only 182, but on May, we started having a lot of swabs through drive-through. The candidates were asymptomatic contacts, travelers, healthcare professionals, pre-procedure, and the number of swabs were increasing a lot. As you can see here also, once we started the summertime, the number increased dramatically. I remember the time that we had to swab the candidates through the drive-through in the summertime in Ramadan, where everyone is fasting, and it was really appreciative and rewarding by receiving a lot of comments from the candidates who are coming through for tests, thanking the team and thanking us for all the efforts that we are providing. Hassan Hamid says, and I quote, "During the curfew, I was in charge of manually preparing a declaration form tailored to each patient. Once, I had to prepare more than 400 declaration forms for mass swabbing." So this is just give you a bit of example how much the nurses were really working hard in order to maintain the mission. Involved nurses and other healthcare providers were trained in nasopharyngeal swab, PPE, donning and doffing, N95 fit testing, and proper training. All of these skills and procedures were had to maintain all the time in order to provide the best experience for our candidates. Nurses had to work hard on all the steps, starting from contacting patients to complete Ministry of Health forms and prepare swabs until providing swabs results and a follow-up. Because of the number of the swabs that we have done, we have to formulate a team made up of nurses and physicians to deliver the results and follow up a procedure to our candidates or our swab patients and families. That's not only in Dhahran, that's also in districts. So they were informed on a daily basis about their results and follow-up instructions. We believe that health education was the key component during the result dissemination. Emergency department also supported the PCR swabbing through facilitating healthcare provider swab to expedite return to work procedure, especially after quarantine and curfew, and also accommodating overflow from drive-through testing stations. As the dynamic of procedure from Ministry of Health and Command Center and JHAH has been changing over and over as a response to the new data that we receive and we know about this virus, fast-track PCR screening for admitted patients was also initiated, and pre-surgery PCR screening was also part of the PCR swabbing efforts in JHAH. And now I would like to invite Dr. Maysa Rab'an to talk to you about training and staff preparation.
Thank you, Islam. Good morning, everyone. Now I'm going to go with you through the nursing training staff during the surge. We managed to train 1,261 nursing staff on PPE, and we managed to train 945 nurses on how to take nasopharyngeal swab procedures. It's worth mentioning that none of the staff contracted COVID from patient encounter, which indicate our robust infection control and the adequate training our staff received. In preparation for the staff to take care of critical care patient, we managed to upskill 27 staff from different areas around the hospital. 60 staff also attended the ICU crash course that was conducted by the Office of Academic Affairs. During this year, cross-training policy was updated and finalized to be in alignment with lessons learned from the surge. Because of the ICU bed shortage during the surge, emergency department were trained in how to take care of ICU patient according to the ICU guidelines. Continuous renal replacement therapy was part of the treatment plan for COVID patients. We have increased the number of CRRT certified nurses to take care of CRRT patients. So we managed to train 24 nurses between Dhahran and districts. CPR trauma and rapid response processes were changed to incorporate the 2020 AHA and Emergency Nursing Association guidelines during pandemic, meaning that all patients requiring resuscitation were considered as infectious until a swab result comes out. Emphasis on full PPE and all resuscitation took place in the negative pressure rooms. In a collaboration with Respiratory Therapy Department, we also introduced another modality of oxygenation, which is the high-flow nasal cannula. Also, clinical pathway for COVID-19 patients were created in collaboration of the QI department to standardize the care. CRRT protocol was changed to accommodate the pathophysiology process of COVID-19 patients. It's worth mentioning that although our resources were stretched during the pandemic from beds, equipment, and staffing, the quality of patient care was not affected. There was not any increased incidence of VAEs, COTIs, CLABSIs, or pressure injuries. and patient satisfaction scores were the same as it was before, or even higher in some of the areas. We collaborated with facilities to increase the number of negative pressure rooms and clinic, emergency department, and inpatient units. Also, there was a temporary change in our cohorting policies. We allowed cohorting families in some of the areas as the pediatric floors. We would like to take this opportunity to acknowledge the role of the nurses who were in the lockdown areas and local hospitals to provide care for patients who couldn't access JHAH facilities during lockdown, such as oncology and hemodialysis nurses. Now I'm going to leave you with my colleague Islam to talk with you about the quarantine facilities. Thank you.
Thank you very much, Dr. Maisa. So one of the things that I like about the pandemic, if there are bright side, is that it explores a lot of potentials in our nurses throughout a lot of services that we have created in JHAH. One of them is the nurse-led support lines. So there are different lines that we have initiated as a response of the pandemic situation. Some of them were already available, but were expanded as a result of the high demand. The first one is nurse-led patient education advice line, where the nurses contact those who are candidates for wound care, congestive heart failure, diabetes, as a result of shutdown services during the surge. Nurse care line also is a good example of the services that was available before the pandemic, but had to expand to more than duplication of the stations. We started with 3, we end up having 7 stations operating continuously to accept hundreds of calls on daily basis. They are all run by nurses and only nurses, well-trained nurses performing assessment, providing advices and necessary education. They are having protocols, they work through the protocols to standardize their responses to the patients, at the same time to assign the patients where they are supposed to be assigned. Nurse care lead is also considered one of the great examples of best utilization of nursing experience in assessing high-risk symptomatology or history of contact. Nurses practice advanced decision-making in this service. So working in harmony with the drive-through to provide COVID-19 screening in the safest and most efficient manner. The next topic that I would like to talk to you about is the quarantine facility, which we thought that we are going to experience before the pandemic in JHAH. We were just reading this in the books and hearing stories all over the world, but we came to a time that we have to think about quarantine facility. We started initially quarantine facility to set up for only 120 guests, in which JHAH hosted Saudi Aramco employees, students, and family members who returned from international flights. But guess what? Things have changed dramatically and rapidly, and the demand has increased on a daily basis to reach up to 7 quarantine facilities operating at the same time, hosting more than 1,928 guests. Protocols, procedures were not in place at that time, so we had to start from scratch, working on protocols and procedures to develop and manage the multiple cycles of arrivals and identification, registration, testing, and discharge for different cohorts. All of these stages were studied very well by multidisciplinary team, including nursing, who were covering 24/7 the quarantine facility. Thanks to the committed and innovative JHAH multidisciplinary team, especially the nurses who worked so much hard on every single step. I still remember in the one of the quarantine facility that we have to receive 5 to 6 buses from the airport coming at the same time with their luggages. We have to plan to move them safely and effectively from the parking lot to their individual room as fast as possible. It was challenging, but at the same time, it was rewarding at the end of the day that we see our mission has been completed with high satisfaction from our guests. Mass swabbing also was another big day in quarantine facility. And it also highlights the strengths of nurses meeting the demand, utilizing out-of-the-box processes to accommodate requirements in JHAH as well as Aramco. You know the high standard of Saudi Aramco that we have to meet all the time. So we had to work on our best and beyond our best in order to accommodate their requests. I still remember how nurses were contacting the guests, filling up the forms, answering their medical concern and their psychological concern as well, responding to their families' questions on daily basis around the clock in order to alleviate their tension and provide them some information which hopefully will make them feel better. And now I would like to invite Mariam, who will be talking to you about home monitoring. Thank you.
Assalamu alaikum. Good day, everyone. It's a great opportunity to be here and share with you our experience during COVID-19 pandemic through talk about our rules in home monitoring. In the beginning, actually, when I was asked to prepare for this lecture, I keep searching on the literature to see about the concept of remote patient monitoring, and I found it is in less than 200 years ago, the patient, when becomes sick, they will receive their treatment in a home setting by the physician who either from their family member or midwife or neighbors. So the remotely patient monitoring is a treatment method enhance the physician ability to monitor and follow the patient condition in non-traditional healthcare setting using technology tools to transmit the health data from patient and in his or her setting to the healthcare provider in a hospital setting in order to manage and monitor the patient condition. During COVID-19 pandemic, there is a lot of initiatives done globally and in our organization, Johns Hopkins Aramco Healthcare, as well as it covered by my colleagues. But I will focusing on, in the beginning, all the positive cases of the COVID-19 was dealt with it by either admitted them to the hospital or to zone to quarantine facility. And after a while, the numbers actually dramatically increased. And by reviewing all the cases, we discovered that the majority of the cases either asymptomatic or with mild symptoms. So there was really a need to think about a new strategy to deal and continue provide appropriate medical and psychological support to our patient and comply with the Ministry of Health guidelines to avoid spread the infection. So from that was the Home Monitoring Center created on June 8, 2020 as it is primary care initiative comprised of a physician, outpatient case management, and admin personnel. Our patient or our target population was all Johns Hopkins Aramco Healthcare registered patients among the district who they are positive and either asymptomatic or with mild symptoms, without or with a stable chronic condition, and their home setting is suitable for isolation, and we can define the suitability of a home setting by having a separate room. The patient, they need to have a separate room, a separate toilet, and available tools to upload the apps programs, the Ministry of Health apps programs, which is Tataman Tawakkalna, and ours is My Chart. And we actually receive the major resource of our patients. We get them referred from the primary care admission team who receive the positive cases directly from the lab or from the epidemiology or infection control. And the other two resources is either from the a COVID line when the patient reports their results after they did the swab in Ministry of Health, or if the patient discharged from the hospital or from the quarantine facility and they did not finish the whole period of the home isolation, which is 10 days. So they will refer them to us to complete their follow-up with them till they finish the 10 days. Okay, so on a daily basis, we actually in a home monitoring center dealt with three categories of the patient. I will divide them to new case, follow-up, and discharge cases. On the new cases, actually, all the registered patients, after they're enrolled to our centers, they will receive a call on the first day to assess their medical condition, assess their symptoms, and make sure their home setting is suitable for home isolation, provide them all the expectation during home isolation, answer their issues, and reassure them, explain to them the red flag symptoms and when they need to search the medical team attention. And we'll define them the duration of home isolation, which is 10 days starting from the day following to the swab date, and we will inform them the discharge dates as well. And we will encourage them to upload the, as I said, the Tatamman and Tawakkalna apps programs in the MyChart. And the follow-up cases, those the current active cases, which we will keep following with them on a daily basis, either by phone call consultation or through MyChart. And when the patient answer one of the question, because we will keep sending them questionnaires on a daily basis through MyChart. So if the patient answer one of the symptoms by yes, that's meaning he or she have a symptoms, or the patient reach one of our healthcare provider either through the COVID line or by visit emergency room or urgent care unit in primary care, they will receive a call for evaluation and assessment. On discharge cases, when the patient reaching to the last day, which is day 10, all the patient will receive a call to assess their symptoms and make sure they are asymptomatic for the last 72 hours. Then we will discharge them from the services and we will issue them clearance letter, and their health status will change on a Ministry of Health database from the active case to recovery case. In this graph, it will show like a summary of the average number of our patients we received from the time we start till this moment. As I said, the average, we start on the third quarter of 2020. The number of new cases we received on a daily basis, on average 80 cases, 300 follow-up cases, and 60 cases discharged. In the last quarter of 2020, we experienced a drop down on the numbers of the cases to 15 new cases, 70 follow-up, and 8 discharge. Then at the beginning of this year, this actually report is run till the end of January. The average number of new cases, about 2,720 follow-up and 15 discharge cases. And on this table, it shows the total accepted number under home monitoring services till, as I said, 31st of January was 5,882. And thanks God, alhamdulillah, from those numbers, 91% total cured and be able to complete the whole period without any complaint and any issues, with 5,363 patients. And only 337 patients, we admitted them to the hospital, and 90 patients admitted them to quarantine zone 2 facility. This graph shows the percentage of the cases distributed among the district, and you can see the big percentage on Dhahran with 54%, and the rest of the percentage is distributed among the other districts, 26% on Al-Hassad, 12% on Ras Tanura, and 8% on Abqaiq. The satisfaction, actually on Alhamdulillah, this service was well appreciated and received by a patient and on organization level. On a patient level, it was really more convenient for the family, especially with the patient who is young child or elderly people, where the quarantine will be more challenged if they will quarantine them on a hospital or zone 2 or the quarantine facility. On institutional level, also this program helped to free up the load on a hospital and avoid the necessity of open another quarantine facility. At the end, during the COVID-19 pandemic, the remotely patient monitoring strategy was functioning very well during this and provide really a remarkable result in order to continue provide appropriate medical and psychological support to our patients. Thank you. I will handle the conclusion to my colleague Zainab. Okay.
Thank you, Mariam. So 2020 was a year of unprecedented challenges and offered continuous lessons in perseverance and adaptation. I am sure all the nurses share my sentiments that the biggest reward comes from seeing our patients recover and go back to their homes and their families. We have received many thank you notes, flowers, and photos from patients and their families conveying the excellent nursing care that they have received within our facilities. One of them is Mr. Soriano, whose picture you see on the screen. Mr. Soriano is one of our COVID-19 survivors who had a very lengthy ICU stay. He was critically ill, he was intubated, mechanically ventilated, and on CRRT. Had made the miraculous recovery to go back home in the Philippines. These photos were shared with us by his wife, who's a nursing colleague herself, and she have told us that Mr. Soriano have conveyed his appreciation to all of the nurses that took care of him during his lengthy stay, from resuscitation in the emergency department to his lengthy stay in the ICU and during his recovery in step down and regular floors. Thank you, Mr. Soriano, for sharing your story with us, and on behalf of all of us, we wish you a long, healthy, and happy life. And to all our nurses who thank you for showing patience, grace, dedication, and professionalism throughout this year. You are one of this organization's most precious assets. And on behalf of everyone who is listening in today, we thank you and we salute you. Thank you.
Thank you very much to the wonderful nursing team. It was a really lovely experience. From my side here in the panel, I don't have any question. I'm not sure in the main auditorium, Tagreed, if there is any question, please go ahead. Okay, apparently there is no more questions. So I guess we are wrapping the nursing team effort and we are moving to the next session. Our next speaker is Ms. Huda Sayyid Ahmed. She is Johns Hopkins Aramco Healthcare Quality Specialist working in accreditation, and Ms. Huda will present the impact of accreditation on the healthcare quality and patient safety despite the COVID-19 challenges. She's going to demonstrate Johns Hopkins Aramco Healthcare experience. Actually, thanks Huda, this looks so lovely to me. And please join me in welcoming Ms. Huda.
Assalamu alaikum and good day for everyone. And I'm so thankful to the organizing committee to giving me the opportunity to present our research study with my colleagues in accreditation division, which was about the impact of accreditation on healthcare quality and patient safety during the COVID-19 pandemic from Johns Hopkins Aramco Healthcare experience point of view. So as any research work, my presentation will cover the background, objectives, methods, results, and then the conclusion. So to start with, as you all know, the accreditation programs or accreditation bodies has gained a worldwide attention to address the medical errors. It helped a lot in reducing the medical errors by improving the delivery of quality of healthcare and also enhancing the culture of patient safety in all healthcare organizations around the world. Here, our organization in Johns Hopkins Aramco Healthcare, we are designed to enhance the community well-being by providing integrated and best of care to our beneficiaries, either Aramco or JHAH beneficiaries. We were accredited by Joint Commission International or JCI from international level and by Central Board of Accreditation of Healthcare Institution or SIBAHI from national level, and also we are accredited by Planetary as a golden person-centered organization. Here in JHAH, we are utilizing the accreditation programs to support the STEEP framework of healthcare dimensions in order to ensure providing a safe healthcare in a timely fashion and making sure that this healthcare is effective and efficient and equitable to all patient levels, regardless of any difference factor, and also patient-centered care, taking into consideration patient wishes, values, and all other factors. As you all know, during the year of 2020, it was a challenging year because the world has witnessed a global crisis because of COVID-19 pandemic, and all the healthcare organizations around the world has witnessed many challenges in the healthcare provision, and especially here in Johns Hopkins Aramco Healthcare, we have an extra challenge because it was the year of re-accreditation or accreditation renewal by both accreditation bodies, JCI and SIBAHI for us. And our organization, our management here did not want to postpone this survey visit actually because as a total quality management strategy, which is followed by our management, we are continuously prepared for any kind of these visits, either by accreditation bodies or by Ministry of Health all the time. And one more important factor is that our management are highly confident with our staff that they can do a marvelous job during any crisis. Another factor which was challenging for us because of the COVID-19 precautionary measures, of course, our weekly accreditation meeting has been stopped except for virtual meetings, which just to ensure the continuity of the continuous preparedness for the JCI and SIBAHI accreditation. Also, the tracer rounds, the audits, unit visits were also very limited because of the precautionary measures, as you all know. We were also, of course, required from the Ministry of Health and also SIBAHI, we were required to ensure a proper infection prevention and control process. We were working in collaboration with infection control team to ensure that we are compliant with all the guidelines from Ministry of Health and SIBAHI, and also ensuring the presence of enough infection control supply. One very important factor which was really challenging for us during the pandemic year, we witnessed here in JHAH an absenteeism, a good percentage of medical staff were absent from the workplace. About 20% of JHAH medical staff were absent from the workplace because of the COVID-19 precautionary measures and emergency guidelines, especially from the period which was from March until at least the end of June. It was one of the main precautionary measures was affecting this is the lockdown of the Qatif Governorate, which was in which a big number or a high number of our medical staff were residing in there, including nurses, physicians, pharmacists, and other healthcare alliance providers. And also due to the other Ministry of Health guidelines, including the pregnancy, breastfeeding, chronic disease, and so on and so forth. So you can imagine how the shortage of the staff, how it created a stressful environment for both the staff who were working here under the precautionary measures and the pandemics and everything, and also for the patients who were admitted during that period. or who were required to visit the hospital for emergency services. So in 2020, the world witnessed a global health emergency as a result of COVID-19 pandemic. However, the accrediting bodies can continue efficient patient care and how is that is by monitoring the key performance safety goals, which is by continuing the International Patient Safety Code commitment to the International Patient Safety Code goals requirements, which are set by the JCI, or the corresponding 20 essential safety requirements, which are set by SIBAHI. So our objective for our study was, this was a cross-sectional study. It was meant to evaluate the accreditation process and assess its impact on healthcare quality and performance in compliance with the JCI requirements for the 6 international patient safety goals within JHAH facility services from the beginning of 2017 until the end of 2020. Additionally, we wanted to align the performance of these goals together with the patient experience, which is represented by patient satisfaction rates. So the method was as follows. We are using the 6 international patient safety goals as our key performance indicators for our performance within Johns Hopkins Aramco Healthcare to measure our performance. At the same time, we have another KPI to measure the patient or the customer satisfaction, which is represented by the patient satisfaction rate, and we were using for that the Briss-Gainey survey. Both data are collected on monthly basis and collected for this study. The data from January 2017 until December 2020 were recalled and statistically analyzed for the study. So what we will see is that the performance of each individual patient safety goal, or IBSG, will be illustrated in a run chart alongside with the patient satisfaction rate during the same period. So what we will see during the analysis for the result for the IBS goal 1, which was set by JCI to identify the patient correctly, the analysis will reflect the commitment of JHAH staff in using the correct 2 patient identifiers as per our policy, which is, as per our policy, is the full name and governmental ID or IQAM number for non-Saudis. For the second IBS International Patient Safety Goal, which is set to improve the effective communication, the analysis will show you the compliance of utilizing JHAH staff with the proper communication tools as per defined as per our policy, which is communicating, for example, the critical values or critical results for laboratory critical values or radiology critical values, telephone calls, verbal orders, telephone orders, and verbal orders, and so on. For the third international patient safety goals, which was set by JCI to improve the safety of high alert medications, the analysis will reveal JHAH staff compliance to all medication management elements required by the accreditation body, in this case is JCI, to ensure the medication safety. For the fourth international patient safety goal, which was set by JCI to ensure safe surgery or invasive procedures, the analysis will indicate JHAH surgery and invasive procedure team for OR and OPA adherence to all requirements that ensure safe surgery or invasive procedure, including briefing, site marking, time out, sign out, debriefing, and so on. For the fifth international patient safety goal, which was set by JCI to reduce the risk of healthcare-associated infections, simply the analysis will reveal the compliance of JHAH staff in performing proper hand hygiene. And finally, for the sixth international patient safety goal, which was set to reduce the risk of patient harm resulting from falls, the analysis will show the obedience of JHAH medical staff in assessing patients, inpatients and outpatients as well, and performing the appropriate intervention in case it was highlighted as high or moderate risk of falls. So in the result, for the 6 consecutive slides, you will see 2 run charts. One, which shows our performance for each international patient safety goal during the 4 years from the beginning of 2017 until the end of 2020 in a blue line, against a target value which is plotted in a red line. And as you see here, for the first goal, we were doing like quite fine above and down the target value until a glitch was what happened like for a period of a few months, and I think it's like kind of 1 year, because we changed our policy from using the badge number or the Aramco badge number as identifier into governmental ID number or IQAM number in alignment with Saudi Arabia laws and regulations. So we witnessed like kind of struggle with the staff and even the patients, but with continuous quality improvement projects and education sessions, the staff were really committed to be compliant with the standards requirements as well as our policy. And as you can see here, the performance were like above the target than even the year of 2020, which was the year of pandemic. And aligning this performance with the patient satisfaction, which is illustrated here in the red line, as you can see, during the same period for the 4 years, as you can see here, when we are performing well, it's really in parallel with patient satisfaction. So when we are performing well, patient satisfaction will go high, and when we are performing annual or like below the target, the patient satisfaction will also go down. But we were really successful with the commitment of staff to be compliant with the policy and the standards. We succeeded to reach to maintain the patient satisfaction up to 95% during the pandemic year. Same thing for the second international patient safety goal. As you can see here, we were doing also again fine above and around the target until we have another glitch here for the second goal, which is because of changing our electronic health record from using SAP into EPIC. So EPIC introduction here has created kind of like low performance, because we struggled at the beginning, all the software struggled at the beginning to be committed to all the EPIC features and functionality, but with, again, a continuous quality improvement initiatives and monitoring the process, we were really succeeded to perform above even the target, especially during the pandemic year of 2020. Aligning this performance with the patient satisfaction, it's really parallel with the patient satisfaction, but we were also successful to maintain the patient satisfaction up to 98.5% during the pandemic year, as you can see here. Similarly, the third international patient safety goal performance during the 4 years were also quite fine, except for random points here during the 4 years. But we succeeded also to be performing very well above the target, especially during the pandemic year, and aligning this with the patient satisfaction rate. We were doing like a quite excellent job maintaining the patient satisfaction above 95% until it is 99.4% during the pandemic year. For the fourth international patient safety goal performance, also we are doing a really great job during the 4 years without any glitch, without any random points. We were doing above and down the targets, and we were doing excellent job above the target during the pandemic year, as you can see here. And also aligning this with the patient satisfaction rate, we were really doing a great job above 97 to 98%, especially during the pandemic year. For the fifth international patient safety goal, which is basically the hand hygiene obedience, and as you can see here, we are doing quite a good job above the target or around the target, and we were really, this run chart will show you how our staff in JHAH here are committed really to patient safety, and the patient safety culture here is really enhanced, and especially during the COVID-19 pandemic year. Aligning this with the patient satisfaction rate, we are also, as you can see, it was parallel with the patient satisfaction. We kept our patient satisfaction above 95% until we reached 97% during the pandemic year. The last goal, which is international patient safety number 6, to reduce the patient harm resulting from falls, the performance was quite excellent during the 4 years, and especially during the pandemic year. And in aligning this with the patient satisfaction rate, we also succeeded to maintain our patient satisfaction rate until above 95% during the pandemic year. For the all international patient safety goal goals, performance in aligning it with the patient satisfaction, The statistical analysis showed a Pearson correlation of 0.94 with a statistical p-value of less than 0.05, which shows our significant performance, which is directly aligned with the patient satisfaction. So in conclusion, despite the challenges, we at Johns Hopkins Aramco Healthcare uphold our high standards of accreditation activities, and our exemplary level of staff performance was really not threatened by the crisis. And as we continue to navigate the challenges of COVID-19, JHAH assures that our medical staff are committed to providing a safe and sustainable level of healthcare to our patients. Obviously, successfully passing accreditation amid the struggles of COVID-19 pandemic is a testament, and it's a pay for performance of individuals and institutions who have continually risen the challenges. And I'm glad here to announce that we were able to pass CBAHI accreditation last November with a score of 95%, and JCI re-accreditation in last December with a score of 98.8%, with even a significant impression on, from the surveyor side. And finally, and this is like the main message of our study, achieving and maintaining the accreditation status during such testing time, extraordinary year of 2020, it strengthens the patient's confidence in our facility and its leadership. We are proud to be providers for quality healthcare services with proven patient satisfaction. Thank you so much for your time.
Thank you, Dr. Huda. Can you just stay for a while, Dr. Huda, if we have any questions? From my side here in the panel, I don't have any questions from the online audience. If there is any question to Dr. Huda from the main auditorium, please go ahead. No questions. Okay, thank you, Dr. Huda. Wonderful journey, and it was really a challenge to get to accreditation with high score during this pandemic and the challenges of everything around the world globally. This time we're going to move to the next session, which is workplace safety during pandemic, fighting the invisible, is the title of the next lecture that will be presented by Dr. Ahmed At-Tayyar, Johns Hopkins Aramco Healthcare Occupational Medicine Specialist. Please join me in welcoming Dr. At-Tayyar.
Thank you very much. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. Good morning, good afternoon, good evening. Ladies and gentlemen, it is an absolute pleasure to be presenting to you today and being part of this Patient Safety Symposium. I've had the pleasure of actually titling my presentation as Fighting the Invisible. The reason for the title is when we're dealing with the unknown, it is invisible, either to our eyes or to our minds. As one of my professors once said, the eyes cannot see what the brain does not know. Oops. Sorry. And basically this presentation will cover high-level concepts of workplace safety. It applies mainly to the hospital settings, however, can be extrapolated to other working environments. Quick disclaimer, I have no conflicts of interest to disclose. My opinions are expressed in this presentation, do not necessarily reflect those of the organization. Okay, the outline, basically, I'm going to try to cover how globally COVID-19 was tackled through the 3 T's, and I'll talk about them later. I'll introduce the principles or pillars of safety. Then I will shift into talking about the 6 P's of prevention through my eyes. And finally, we'll conclude with high-level recommendations and come to a conclusion. I'd like to start off with a quote by Dr. Michael Ryan from the World Health Organization. Speed trumps perfection. The greatest error is not to move. Those words come very dear and near to my heart, because as I've seen and witnessed throughout this pandemic, sometimes perfection can be the enemy of progress, and being indecisive or having delayed decisions has a significant negative impact. So that is one of the lessons that I took for myself, and I hope the organization and other organizations take dearly. COVID-19 globally has been tackled through the 3 T's approach. Basically, the first T is testing, the second is tracing, and the final T is treatment. With regards to testing, once we have a test that is specific, sensitive, affordable, and easily administrable, this test helps makes the unseen or unknown seen and known. And we've seen this through the efforts in fighting the COVID-19 pandemic. Oops, sorry, this is very sensitive. And again, the test has helped make the invisible visible. The second T is about tracing. So tracing played a major part in our fight against the pandemic. And again, we had unconventional tracing. We had to implement the typical or conventional tracing where we call people up and ask them for information. We had to expand and use innovative methods using different devices and applications to enhance the tracing. And by tracing, we were able to identify the populations at risk, the modes of transmission, and get a better understanding of our invisible foe, which helps us down the line in preventing and fighting our enemy, in this case, this virus. And final T is treatment. So ultimately, we aim to reach a definitive treatment. However, part of the treatment spectrum is actually preventing the infection. And that's achieved by the basic precautionary measures that we've spoken about, the 3 W's, washing your hands, watching a distance of 2 meters, and wearing a mask at all times, avoiding the crowded environments. And again, those basic methods play a major contributing factor in keeping us all safe. On the same spectrum of the treatment, actually, is the vaccination. So vaccination is critical to the fight against such foes as we are dealing with the COVID-19 or SARS-CoV-2. So I would highly advise, actually I would highly appreciate the global efforts that have streamlined the development of the vaccine in such a short time, and now the rollout of the vaccine. So it is up to every one of us to contribute to the safety of others by taking the vaccination. Okay, now I'm going to shift gears a little bit and talk about 4 principles of safety from my perspective. Think about them as categories. So we'd like to ensure safe people, safe environment, safe processes and procedures, and safe knowledge. By safe people, I mean all people. Don't only think about the patients, the healthcare workers, think broadly. Everybody contributes or falls into this category. And by thinking about all categories of people and ensuring their safety, we ensure, by addressing all of those categories, we ensure the safety of all. Safe environment, so think about not only your work environment, but also beyond that, your home, the public areas. We have to take those all into consideration. Safety doesn't check in and check out. It doesn't, you can't just say, well, I'm going to practice in a safe environment between 7 and 4 and then discard that when you move beyond your workplace. Think about safe processes and procedures. Again, this is from a general principle. Processes and procedures need to be reevaluated and modified to address the unknowns. We need to learn, and as we gain more and more knowledge, we need to modify those processes and procedures and have the adaptability and flexibility to enhance the safety of those partaking or participating in the care of individuals, those who are coming to receive the care, and everybody outside of the walls of our organization. The final pillar or principle is safe knowledge. And we've seen this as a challenge. There are multiple channels of information. We've seen the social media, we've seen the general media. They give you a lot of information. It's like, if you'd allow me to use this analogy, it's like drinking from a fire hose. And you don't know exactly the quality of the information that's being shared unless it comes from a trusted resource. So we've seen Thankfully, the Ministry of Health has done great efforts in ensuring that they are the source of truth for all of us. Johns Hopkins Aramco Healthcare has also followed suit and ensured that they are a source of safe knowledge, take the information from the subject matter experts, digest that information, and share that information in a safe manner. Okay. Now let's quickly list the 6 P's of prevention. So first, after listing them, I'm going to have a slide on each. So quickly, just to prep your mind, the first P is prepping the mind. The second is planning. The third is processes and procedures. The fourth is people. The fifth P is passage and physical space. And the sixth is preparedness. I'm hoping there's some comments coming on the system right now saying, Doctor, you've actually listed 8 words that start with the letter P as opposed to 6. And that is another important lesson that I'd like to share with you. You have to be able to speak up and not be afraid to highlight errors. In addition, you should be able to be and encouraged to highlight risks and hazards that you see, especially in times when you're dealing with crisis or unknowns, because what you perceive might be missed by entities that might benefit from your perception. Okay, this is really sensitive. Okay, so prepping the mind. It is not business as usual when you're dealing with pandemics or crisis. That is very important to know. Once you shift your mindset that it is not business as usual, you rethink how you do your business. And I use that term liberally. Act fast. Time is not as a luxury as we've seen. So you don't have to be perfect in your actions. However, you do need to be moving. The new normal. We struggle with this, and we've seen this throughout this pandemic. Initially, people had different perceptions about how long do we have to cope with these, basic precautionary measures. How long do we need to change our practices and procedures? How long is this going to impact us both at work or at home and socially? Well, the faster we adopted the mindset that this might be the new normal, the less resistance we have, and the more likely we are to move forward in the right direction. And again, the key word is adapt to the new normal. In cell biology, they have a simple rule, basically. It says adapt or die. So I think throughout our nature, we've always found a way to adapt, and thankfully not only adapt to survive, but to thrive. We've seen that through multiple areas. Again, all my colleagues who have presented before me have highlighted those areas, so they've made my life a little bit easier. Again, we've needed to do a lot of innovation on multiple aspects of our life, both at work and outside of the workplace. Never assume knowledge. This was very dangerous also, as we've seen. We kind of tried to simplify things. Initially, we said, well, we're dealing with this virus. It's from this family, so it's probably going to act this way. And then, as we've seen, those assumptions, without following up and actually looking at this information, exploring it, studying it, and advancing our knowledge, could have led to serious issues and more challenges. And then I would like to highlight 3 points about mindset. So when you're dealing with the unknown in such a situation, try to be on the cautious side. However, don't let fear paralyze you. You can adopt the mindset if you're working with an infection process. Think about presumed infectivity. So presume that you are infectious, others are infectious, the potential infectivity of the surfaces around you, and act accordingly. It is hard to dictate every single action. It will take volumes and volumes of books to describe every single action. So if you take that mindset, that might help you in your day-to-day decisions. And always, if you have access to a subject matter expert or a source of truth, kindly reach out to them. We have to change our mindset as a healthcare organization or healthcare system. Instead of, in the past, we used to think, how can we provide the services? How can we bring the people to the healthcare facility to provide the services? We've quickly needed to readapt and change our thinking into how do we still provide the service? however, by keeping individuals out of certain facilities, whether it's a healthcare facility or others. And we've seen multiple innovations towards this, talking about telehealth, phone visits, enabling people to work remotely, and so on. Plenty of examples. And the final point on this is protect yourself and others at all time. So protecting yourself is critical, because if you don't look after yourself, then you are unlikely to be able to look after others, and you could pose a risk to others, as we've seen through this pandemic. Protecting others actively, so you have to actively share accurate knowledge and adequate advice. And the final word from the sentence is at all times. And this is critical, because a lot of us are very good in adhering to certain safety measures for a certain amount of time in a certain setting. For example, our workplace between 7 and 4, we are able to maintain those high standards. However, once you exit your workplace, you should still be actively protecting yourself and others and adhering to the basic precautionary measures. And again, we've seen this in the community. And again, some of the data supports this. As you can see, alhamdulillah, thankfully, we haven't had any infections proven to be related to the work per se. However, most of the infections have been related to inappropriate practices in the community. Okay, so the next P is planning. Again, at a very high level, every organization has plans. These plans are not set in stone. They should be relooked at, revisited, and then modified accordingly. These plans should incorporate inputs from every level. Ideally, if you have plans within a department, have those plans shared all the way up to upper management and your leadership. Also consider, when you're developing a plan, the interdepartmental effects of a plan. So I'll give you an example. If you have a perfect plan for your service, try to ensure that that plan does not have a negative effect on another service. So I discourage the silo approach to developing a plan, but rather a more wholesome approach to developing a plan. Incorporate the ability to ramp up and ramp down. Think of it as, instead of a light switch that turns on and off, as a light dimmer, where you're able to control the services and say, I need to enhance the services in this area, I need to cut down on this area to allow growth. It's like you're maintaining a garden. However, it's more challenging, it's expedited, and it's much faster. We've heard the term surge, the surge planning. So surge planning, again, takes into account when there's an increased demand that might stretch your resources or go beyond your resources. So we focus a lot on the threat a lot of the time. So how can we serve, for example, COVID patients or COVID-19 patients? But you have to remember that, things don't happen in series in life. A lot of things happen in parallel. So there are still people who are having strokes, heart attacks. They still need to look after their chronic medical illnesses. So we cannot forget about those. We need to still address those. However, we will need to prioritize our services and then allocate our resources accordingly. We've seen globally that there is a lot of focus on healthcare systems increasing their efficiency. However, this pandemic has helped us realize, or I hope it has helped open the eyes to the importance of refocusing also not only on efficiency, but also thinking about resiliency. So building resilience and reserve, not only in your supplies, but in your actual most valuable assets, your manpower, your people. And again, we can discuss that in more detail. Every single level of an individual should be addressed. It sounds complex, and it probably is. However, complex problems can be dissected into simple problems, and then those simple problems can have simple solutions. And finally, when you're thinking about also, again, going back to search planning, don't think only about your organization, but think about the community as a whole and on a national level. Think about how you can contribute to the community, because by your contribution to the community, you contribute to your abilities. Think how, and also not only how you can serve the community, but how the community can serve you. And then we heard about the new norm. So you should have a new normal plan. My general advice is any plan should have phases, and ideally cater or tailor those phases to your needs. Next, I'm going to talk about processes and procedures really quickly. I'm just going to utilize the inverted hierarchy of control pyramid. I just want to bring to your attention, at the bottom of the pyramid is the PPEs, the personal protective equipment. And those are effective. They are important to have that, and we've seen that. However, this pandemic has highlighted the fragility of the supply chain, the potential of lack of resources as present. We were very lucky within the organization and the kingdom to have really good investments in supply chain and securing this for our people. However, it is not the only line of defense or line of control. We have to also incorporate, and it might not be sustainable. So again, you have to think again beyond the personal protective equipment. How can we introduce administrative controls, change the way people work, enabling them to work from home or remotely, enabling the physical distancing further. Think about engineering controls. So for example, the HVAC system. As we've seen, the organization, for example, converted regular rooms to negative pressure rooms, increasing your capacity to handle patients who require negative pressure isolation rooms. Substitute practices that put you or your people at risk by safer practices. And ultimately, if you can eliminate the hazard or risk, eliminate that either through definitive treatment or vaccination. In this scenario, you can apply the hierarchy of controls across the board. In any challenge you face, think about the hierarchy of control and try and apply that to best suit your organization or area. With regards, the people. Okay, so again, I'm not going to spend too much time on this because I think a lot of people spoke about it. We don't only think about, when we say patient safety, it's usually we have to think beyond the patient. So although patients are at the center of everything we do, we have to think about people around them. We have to still provide services, but you cannot provide services for all. At least you might not be able to provide it all the time in a timely manner. So you need to have a mechanism of prioritizing. You need to have emergency, urgent cases, semi-urgent, or routine cases. And again, you go back to ramping up and ramping down your abilities to serve. Staff needs, don't forget about the staff, not only your medical staff, but also your non-medical staff, not only your employees, but also the contractors, your vendors, and beyond that. Think about all. Think about your community. With next P is the passage and physical space. So by the word passage, it refers to a route, basically, and a lot of the colleagues talked about this earlier. How can you make the route that is taken safe? So think about pre-screening. What do you do before a person even leaves? Think about the visual triage. When they get to your gates, what is the best way to ensure that they are safe and others are safe? And then the route planning. Is there ways to making that journey safer? So and shorter and safer. So minimize the time that they have to come into the hospital. Minimize the passage or the route that they have to take, entering to receive a service and exiting that service. And again, you can be very innovative on those and expand on those. This is not meant to be restrictive. It's just like a flavoring of what you can build and expand on. Next is the physical space. Again, think about your current individual space, rethink those spaces, innovate, and explore areas and utilize them as needed, and modify those areas based on the challenge you're facing. Think about the physical distancing. This pandemic has highlighted one potential issue that arose, which is the need for physical distancing. So think about in future designs, when you're building forward, how can you incorporate that flexibility or adaptability into your organizational structure. Not to forget cleaning structure, schedules. So there's a lot of heroes that actually have to maintain and should not be forgotten, honestly. They had to do a lot in a very short period of time. Dealing with the unknown was extremely stressful. They had to learn how to enhance the hygiene of certain areas. They had to increase the frequency of hygiene. And again, that has a toll on individuals. So we try to make their life a little bit easier by taking a minimalistic approach to where we try to have the form, so the clinical area or non-clinical area, minimized to enable to have them to deal with less, basically. So instead of having to clean for example, the whole 200 or 300 seat auditorium, they might just need to focus on 50 seats, for example, and beyond that. Next is preparedness. So again, we're almost at the end of the presentation. Preparedness is a term or a word that will incorporate many other concepts under us. Again, to be prepared, you should have a plan, and you have to have multiple different types of plans potentially. You should have an emergency response plan, a contingency plan, and a ramp up and ramp down plan, or also ramp up and ramp down abilities incorporated into whatever plan you have developed. Think about preparedness of your people. So all throughout the organization, your leadership should be prepared, the frontliners should be prepared, and everybody, as we said earlier, should be prepared. And preparation may take different forms, such as training, enhancing upskilling, preparing alternative types of workforce, so primary workforce and a backup workforce. And it is a labor-intensive process of planning, but if it is done right, the rewards are extremely high. Have the ability to form task force and teams, and those task force and teams should be readily deployable with clear charters and targets and intercollaborative efforts. Share the knowledge. Think about not only utilizing the people within your organization, think beyond that. Think about your community. Think about the contractors and other resources that you might have that you have not tapped into. With regards to materials, supply chain. We've seen how fragile globally this is and how big of a challenge it is. Secure your supply chain. And our people here, again, and kudos to what they've done. We have not felt the strain that the rest of the world have felt, thankfully. And then next is support. So you have to look for support for your employees and for your organization. Think out of the box. Not only seeking support, but actually giving out support. When you are very comfortable in your organization, think about the organizations around you that might be facing the challenge, because helping them now will help you later. And then compliance versus complacency, or let's focus on the word compliance for now. It is easy initially, and I'll use this as a segue for a quick anecdote. Every New Year's I say I enlist in a gym, and I say I'm gonna go and work out every day for the next few months. I do that for the first week, the second week, the third week. I go down to like 3 times per week. By the 4th week, I'm just passing by the gym. By the 5th week, I don't even know where the gym is. So compliance is a challenge. It is critical. So think about how can you ensure compliance, how can you monitor compliance, how can you enhance compliance, because that's a main factor for your safety. And finally, metrics. When you have data is eye-opening. Make sure you have the right metrics. Make sure you analyze those metrics, and also after you do the analysis, adapt the practices to improve your metrics. Okay, how to fight the invisible. This is basically like an overview. So utilize what you know. Even when you think you know nothing, you do know the basics. So go back to the basics. Don't stop there. Make the unknown known. How do you do that? By collaboratively asking colleagues who are more knowledgeable, reaching out to studies, and as we've seen, the WHO has done a great job with the efforts. They've talked about multiple cross-regional studies. Modify your approach as you gain knowledge, and utilize that knowledge to modify your approach. Collaboration. When you're fighting a foe, you are more likely to win if you have friends who collaborate with you to overcome the foe. Innovate. by all means, innovation is not a luxury. It is an absolute necessity. And I would advise every organization to encourage a healthy environment for innovation in tackling any challenge. Ultimately, look after yourself, not only from a physical perspective. Don't forget about the emotional, financial, mental, and social well-being. You need to look after yourself to be able to look after others. And the final takeaways are as follows: be safe, be smart, and be kind. And with that, I'd like to conclude. Before the final words, I'd like to acknowledge every individual within Johns Hopkins Aramco Healthcare, from the top management all the way to the frontliners, both those who are facing patients and those who are working behind the doors, behind closed doors. I'd like to also take this opportunity to acknowledge our leadership, represented by the chairman, Mr. Nabil Al-Jama, and also Saudi Aramco for the continued support and efforts that they have provided us over this whole challenging year, and that they continue to provide. With that, I will conclude and open for questions. Thank you.
Thank you very much, Dr. Ahmed, for the wonderful presentation. Here from my side, there is no more question. I'm not sure if any questions from the main auditorium. Please go ahead.
I think there's no questions. Thank you so much once again.
Thank you very much. So I guess this is the time that we will move to the next session with Dr. Shireen Qurashi, Challenges of a Neurological Disease and Pandemic. And the next session will be presented by Johns Hopkins Aramco Healthcare and neurologist consultant, Dr. Shireen Qurashi. So please join me in welcoming Dr. Shireen.
Thank you very much. Bismillah ar-Rahman ar-Rahim. Alhamdulillah Rabbil Alameen wa salatu salam ala ashraf al-anbiya al-mursaleen. I'd like to thank you all for inviting me to present in this patient safety conference, which is a yearly event that happens at Johns Hopkins in collaboration with Armstrong Institute. Really, I mean, this year has not been the usual year by any means, and we've been hearing the greatest presentations over the last day, and from different colleagues from within our organization and from internationally and nationally. It's very enlightening, and it helps us a lot to understand what is going on, and we're learning from each other. I wanted to give you a perspective of, we've been hearing from frontliners, we've been hearing from people in a global way dealing with the pandemic. And I thought I'll give you, we probably internists or subspecialists or, people, sometimes we're kind of lost into what we have been doing, into the fine details of dealing with neurological or certain chronic diseases, or really diseases, dealing with them in the pandemic. I mean, we have inpatient services, we have outpatient services, and how did we dealt with it, and what were our own challenges? Maybe we were not in the emergency department right there. Maybe we were not the ICU nurses. But we were really everywhere, and our impact was pretty much everywhere. So the effect of the pandemic on a patient care, types of different neurological diseases as an overview, different neurodiagnostics. I mean, when to do what and how to do it, and then the resurgence of teleneurology and how it is. Remember, neurologists, we really take a pride. We say that we are a very cerebral specialty. We take a pride in a very detailed history and physical examination, which is always, has been, people just run away from neurology because, you have a lot of detailed examination. How are you going to do this? And when it became, we were impersonated to how to deal with this, it became a very, knowing challenge to us. then I will tell you our experience in JHAH and what is the future of neurology, what is everywhere. So the effect of the pandemic on the patient care, there has been a limited access to outpatient and non-urgent facilities. This was like, I mean, last year at this time, we pretty much shut down the clinics. We had this order. So how would we deal with our patients? Our inpatients were still there. We had patients, patients on seizure medications, patients on immune modulating therapies, patients with strokes. How would we be dealing with that? There has been a resurgence of telemedicine, and that was one of the things that came up. So to understand how COVID has impacted, we have to learn how COVID impacts the CNS. There has been a lot of publications that were just telling us about the evidence of COVID virus having, a specific predilection to the CNS tissue. This was one of the articles that came out targeting the COVID-19, targeting CNS tissue. It was a neurotropic virus, probably a lot of different mechanisms. We're not going to go into real details, but you've all heard it, that one of the first earliest signs was that, loss of sense of smell and taste. That is a neurological manifestation to us. So that was there. Then became more evidence. Even when the Ministry of Health had put the criteria of dealing with COVID patients, the majority of the neurological patients were falling into high risk patients for admission. So a majority of our patients are over 65. They have chronic comorbidities, diabetes, hypertension, probably vascular diseases. They were obese, and they were on a lot of immune suppressant agents for different reasons. So we were right in there. Then more evidence came that neuropathogenesis and neurological manifestations of COVID virus was a real thing, and it was not just a side thing, and for different reasons that I will explain in the next slide. So it became a big burden. The amount of publications that, I think every night after coming back from work, I was glued to my computer, listening to different webinars, listening to different things, what have been happening in the field of neurology and how we're dealing with that, just, expanding our knowledge. So just to go over, we neurologists, some people just, think, there's some types of different neurological diseases and how they are different. And these are just, for example, these are not all the neurological subspecialties. That makes it difficult to really deal with an acute stroke right there in the emergency department into a chronic disease of somebody who is probably with the chronic movement disorders. I didn't put any other neurodegenerative diseases or, people with different seizures or neuromuscular disease. All those are different, and they all have, different manifestations and different entitlement or way to treat with as an inpatient and outpatient. So those were all there. I would say the headache's not a major factor, but probably not true because, any viral illnesses, you'd have the headache. And here probably I'm talking in terms of the access. It's not a very true statement maybe here. So a fact came to us all that the neurovascular diseases, although I just told you that neurological diseases were more in the pandemics, people were scared really to come to the emergency department. So the number of strokes all over the world globally were coming to the emergency department were less. And although there has been a true increase in the risk of stroke. This was published, and this is not from our own data. This is a global data. So decreasing hospitalization of this was early, somewhere in 2020, in the April to July, or even August type of months, 2020, when people were rather dying at home from stroke probably, or having their morbidity there at home, and rather than they were scared to go to the hospitals, not knowing what would happen. Now they say, oh, I don't want to die from corona. And it's a fact. And this is not national, this is international published data based on multicenter studies all over the world. So that was really difficult difficult, and we had to put a statement to encourage people to come to the emergency department to be taken care of, because you'd have to re-educate. You have to gain confidence of patients that we will be taking care of you. We are safe. What you've heard from the emergency physician yesterday, what you've been hearing from the nursing, how we were dealing with that. We had to, give people the reassurances, come to us. We will take care of you in the appropriate way. Don't be worried. There has been increased risk of stroke. That was also a fact that was published in the American Heart Association related journals, because COVID, as I said, it had its own mechanism of people developing stroke. All the pathophysiological mechanisms of stroke were right there. So large arteriosclerosis was there, ischemic stroke secondary to that, hypercoagulable states, coagulopathies, all those. I'm going to go over into every Asian there, so they were there. So we had to deal with that. The management, therefore, more publications came onto how to manage these stroke patients. And there has been a lot of workflows that we all could adapt, and we started following is how to deal with acute stroke patients, confirmed ones, the suspected ones, the asymptomatic ones, in terms of, your line of flow into the hospital, the emergency department, the investigations that could be done, and whom we can offer mechanical thrombectomy. So we really did not want to compromise their care, because this is important. That is one of the goals of our treatment. The resurgence of people living remotely, how can we help them? The American Heart Association has already, even in the past, set the guidelines about telemedicine and tele-stroke management. This hasn't been old. This isn't anything totally new, but globally this has not been used. So probably with this pandemic, there has been a reuse of these things, and we were encouraging people to do that. And I guess that became, just wanted to say that there has been a resurgence of these. And these are evidence-based ways of dealing with these patients. Moving on to other things like neuromuscular diseases, there has been, people lying with chronically in the ICU for, if you are immobilized for a few weeks, you can develop what we call ICU myopathies, neuropathies. These are neuromuscular disease manifestations, prolonged intubation, immobilization, and then people, some of them just, they may have even some things like Guillain-Barré-like symptoms secondary to viral infections. Sometimes you even get that from post-vaccination inflammatory myopathy. So all these things are related to COVID, and there has been a lot of, association and articles that came out. This is from Amato, who's like at the Harvard, where it's telling us the effect of the COVID viruses onto the neuromuscular disorders. With that also, so these are the potential, you could have GBS, myositis, critical illness myopathies, neuropathies, infections, a lot of manifestations from the medications. All those we needed to know more and update and correlate and answer about those correlation. Then comes another thing, probably not everybody always thinks about, is what type modalities of investigations, when to do and how to do that. We do nerve conduction studies, needle examinations. Is it really needed? Is it always needed? How can I protect my staff, our people? How can we protect our equipment? For God's sake, I cannot be throwing those electrodes every time I use them. I cannot send them for disinfection all the time because I don't have many. We even face this problem here at JHAH. We didn't have everything. So thankfully, the American Academy of Neurodiagnostic Medicine, electrodiagnostic medicine, put some guidelines when to do this one and when not to do that. I faced that in our own setting. What can be done? Of course, we have the infectious disease or disinfection control team, but it's not an easy thing to deal with. Same thing with epilepsy, EEG, disinfection of the electrodes. A lot of the Canadians also put a guideline. I know in the peak of COVID last April or May, I think I had a patient who was really in status epilepticus. So I had at certain time really treat them empirically, not having what I would usually do in terms of, prolonged EEG monitoring or frequent EEGs, because, whereas things sometimes you take that granted, but I have to say my tech will be in that room with their PPE. Yes, we're talking about the PPE, but for how long? And then that machine that I'll be probably using it on another patient, non-COVID. It's a whole dilemma. So these are different manifestations or dilemmas that we have to take care of in terms of patient safety and safety of the healthcare professionals. And there were some guidelines that came out even with that very peculiar aspect. Patients with neurological diseases, multiple sclerosis, immune compromise, risk of infection, their medication interactions. Today, every day I'm having patients who are asking us about the vaccination. What is the benefit? Can I take it or not? Or being on these medications. The Saudi Multiple Sclerosis Advisory Group just last year in 2020, they put some guidelines into that perspective, and we were all part of it. And this is not for you to read, but I'm just telling you that there are lots of, I have this kind of list of disease modifying treatments just for treatment of multiple sclerosis. And these were kind of graded as in green. Okay, these are relatively safe. These are low risk, intermediate risk, high risk. I have patients on all these modalities of medications, depending on what stage of the disease they are and then how to deal with that, which ones I can continue giving them their infusions, which one can continue to be on their interferons or their, oral treatments, which ones can, these are usually young people, and my colleague occupational medicine people know that some of them, they needed to be, advised to work remotely more than the others, and we're given more extended times off and somewhere. And now they come with the issue of vaccination lots. So these are all dilemmas that we kept dealing with. Okay, moving on, telemedicine, COVID. Again, there has been a lot of applications and implementation guidelines. This is verbatim from the Academy of Neurology, which is kind of a reference for we follow. So they have put within that time period last year, they put some guidelines, so that globally people will be encouraged to use the teleneurology setup because it was everywhere an issue. You have to have a clear examination room. Remember, I told you, we do a detailed examination. You have to have good acoustics, lightening in the interior surface, equipment, all those things are important. You have to, you're examining patient at home. We started having the telephone visits and video visits in here too, and all over the world. Patient identification, two-factor identification for safety, consent. You are seeing the patient. Patients get worried. Oh, is somebody recording me? Somebody's doing something, all those tips of performing the neurological examination, if they had some assistance. Remember, some of them are young people, some are elderly people. We have all sorts of a spectrum of patients. Things that are in red probably were limited. We weren't able to do the vital signs, but some aspects of the mental status examination were done a lot of. We do a detailed assessment. We're able to do. And this is example of the mini mental status examination that we usually perform. We're able to do some of it, not all of it. If you had assistance, you would probably start putting a setup how to do those things, and how not to do that. This is another Montreal Cognitive Assessment Test, which we have it in both languages, Arabic and English, and multiple other languages that are available. You could do a detailed assessment, at least some of it, if you are going to follow those patients. Remember, these are older patients, and they will be hard to come, and they are higher risk. They're the ones we have the scoring in our clinics. They're like the 4, 5, 6 numbers, and you can't really be bringing them to come in and have the assessment. Other aspects of cranial nerve examination, of course, you can be doing, through the video, you can be doing the fundoscopic examination, but other things probably with assistance, or the setup is in a place which is closed. The way to set it up is probably there should be central area, which is non-COVID hospital or primary care center that patients could go in, and they have the assistance of, some other healthcare professionals that could help in doing that examination, but you were still keeping the patient safe, and you could do some of the limited aspects of examination, the cranial nerve examination, the motor examination. The ones that are highlighted probably were limited. So all those things came and became, we started knowing what are the things that we could do, what are the things we can't do. Some limited or modified comprehensive examination became available, and some of the limitations were highlighted. But this is all in keeping, what you could do and how to deal with a crisis, yet being safe doctor, being safe subspecialist, providing the best care that you could do despite the limitations, and see what are the other ways. A lot of patients really started liking these visits. Probably sometimes we can see more number of the patients. This is our own statistics. We've had the statistics is from March until January this year. The number of the patients that were seen in person and virtually. As you see here, April, May, June, July. The number of the in-person visits were very limited and started to pick up again. The virtual visits were increasing and kept increasing more. See, in month of June, we saw 640. This is just only the neurology clinic. And we were just the two neurologists working at that time. Patients are now liking it. So this will become our new norm. The hybrid model will become our new norm, and we'll continue doing that because we've all realized that there are a lot of patients that do not need to come. We have means of doing it. We'll probably expand our service. We will put some metrics, objective ways of following these patients, make sure that the standards are not compromised. We are not compromising patient care. Patients are safe in their environment. They have the quality, the best quality of care. They are entitled for their neuro assessment and examination and their medications. And thanks to our pharmacy service, they have done great into providing the specific medications, and we continue to give our patient the best care. So the lessons learned, despite neurology being heavily clinical and person-based specialty, neurologists adapted new ways in delivering patient care. Patients were satisfied from remote visits. We saved time. More patients could be helped, and remote access becoming a new norm. And teleneurology is a new scope and will be incorporated in the new vision. Thank you very much.
Thank you, Dr. Shireen. We have had an information-filled morning, and now it's time for lunch break. I hope you enjoy your meal. The afternoon session will start at 1:40. Thank you.
صار Yes, yes, yes. And then you will be looking. Yes. Yes.
أنا أحمد المعي ما تعرفت عليك. هلا وسهلا. Public relations. أنا قابلت اللي هي إيه هذه في المنزل؟ أنا عشان كذا برافو.
Okay, good afternoon, everybody. This is Dr. Abdul Muttalib Al Masloom. I'm a patient safety officer's co-leader at Johns Hopkins Aramco Healthcare, Dhahran, Saudi Arabia. I will be the moderator for this afternoon session on the second and the last day of the 2021 Johns Hopkins Aramco Healthcare Patient Safety Symposium. So now that you have your good lunch break and stretching out, and you are all fresh and ready for a very exciting afternoon with the theme of this afternoon conference, which will start shortly, Challenges in 2020, Creating a Safety Culture Through Engaged Teams and Frontline Staff. As we are coming to the end of this year's conference, please make sure to have your speakers' evaluation surveys completed today. Also, do not hesitate to share your comments and suggestions for our next year's symposium. Please stay tuned and enjoy our live streaming from Dhahran and Baltimore. For now, I will invite Mr. Joshua Sharp to the podium. Joshua is the nurse manager of cancer care at Johns Hopkins Aramco Healthcare, who will be presenting experience in management of cancer patients' treatment during COVID-19 pandemic lockdown. Please join me in welcoming Mr. Sharp.
Thank you, Dr. Masloom. Salam alaikum. Good afternoon, everybody. I would first like to thank the organizing committee for hosting this event, as well as JHAH leadership. And it's my pleasure to go over the oncology triad's experience and management of cancer patients during the COVID-19 pandemic lockdown in the Qatif Governorate. During this presentation, I'll provide a brief background, state our objectives of our project, some of the initial challenges that were faced, our solution to those challenges. I will introduce you to the Al-Zahra Clinic, and then finally go over our outcome of the project. So as everybody is well aware, COVID-19 is a serious ongoing global health crisis. It significantly impacts healthcare systems' ability to deliver effective and timely cancer treatment. Cancer patients are at an increased risk of death from coronavirus due to their immunocompromised state. In Qatif Governorate initiated a full city lockdown from March to May 2020. This resulted in the sudden cessation of many of JHAH cancer patients' treatments. JHAH cancer patients located in Qatif Governorate were faced with treatment delays, which could affect overall curability and their survival rates. Our objective of this project was, we'll end this presentation, is to highlight JHAH's efforts in initiating a remote cancer therapy infusion center in a complete lockdown zone located in Qatif Governorate during March to April 2020. To ensure the continuation of quality evidence-based oncology treatment to eligible patients in order to deliver safe, effective treatment in a timely manner whilst ensuring the safety of JHAH medical staff and, of course, our oncology patients. So going over a brief timeline of this project, during March 8th, 2020, Qatif entered a citywide complete lockdown. This is 24-hour curfews where no one was allowed travel in between it, definitely outside the bounds of Qatif or within the city itself. On March 9th, the oncology triad met and we developed a proposal on how we can best continue cancer treatment to those Qatif patients. This involved gaining access to Qatif itself to provide those treatments, locating a facility to provide those treatments, and then overall being able to provide treatments to those patients. So on March 17th, not very long after, JHAH oncology staff began their first day of operations at Al-Zahra. On March 18th, our first JHAH oncology patient was successfully treated in Al-Zahra Clinic. And on April 30th, our last JHAH oncology patient was treated in Al-Zahra Clinic. May 3rd, we saw the return of our Al-Zahra team and a return to normalcy back at Dhahran. So some of our initial challenges faced included lots of logistical challenges. Our main one was gaining access to a militarized lockdown area. And I have to thank Dr. Mohammed Al-Ghamdi and his team at Population Health, as well as government services and JHAH HR in helping us along with this. They were instrumental in getting us approval through MOI and through MOH in regards to having travel permits for not only our oncology patients, but our staff as well. Operations, we saw many challenges. Our main initial one is that we don't have an outside chemo center in Qatif. So locating a suitable facility was a prime objective of ours. We didn't have remote EHR access, electronic health record access at the time. So we had established some communications with our Epic team here on how we could do this remotely. And we set up a remote chemo center digitally so that we would be able to check patients in, sign for their medications, release protocols, and effectively document on them. Of course, finding and making sure that Al-Zahra had adequate emergency services was a key factor for us. Many of our patients we pre-medicate before their chemotherapy treatments, but there are at times where they do react. So having a safe, stable area for them was one of our prime objectives. Staffing was a major concern for us. Of course, we had to find available staff to provide the care and treatment to these patients. We were fortunate enough where a few select members of our oncology team were actually located in the lockdown area, and they provided that treatment for us. Secondly, we had to get staff access to the lockdown area, and MOH and MOI were very helpful with us getting those 24-hour travel permits for staff to be able to go to those centers. And we then had to locate allied health staff services such as phlebotomists and other members that were needed for diagnostic testing before we can initiate the chemotherapy. A secondary challenge that we faced was the management of staff from in a remote area. It was a new concept for us to manage staff remotely, and we had to use some situational leadership in that, where we were able to not only provide their well-being and meet the challenges that they faced, but also comfort them in the way that they had some security from the Duran team and that we were there for their support. Supply chain was another big challenge for us initially. We had to make sure that we can gain access to that lockdown area for critical medications and daily clinical supplies. We had to ensure that medication delivery was going to be on time. This is due to the fact that many of our chemotherapies have a set stability time, so any time difference from that, the drug would be expired, which is a huge operational cost. Additionally, we had operational costs of organizing and managing a remote chemo center. This wasn't planned for within budgetary means, so setting up a whole new remote clinic added to that thing. And I have to thank JHAH leadership for being so understanding, as well as Saudi Aramco for additionally supporting our means of providing this cancer treatment to Qatif patients. Safety was a major concern for us, and of course, ensuring that JHAH staff safety, JHAH oncology patient safety with potential COVID exposure was a key element for us in our plans. We worked very closely with infection control, and I'd like to thank Dr. Tawfiq and his infection control team for helping us develop protocols so that we could keep staff as well as our patients safe. We also, our oncologists had to meet together also to see whether it was, safer for patients to receive treatment delays versus having them start a chemotherapy and then potentially have a COVID contraction, because at the time, we didn't know how this could affect an immunocompromised individual. So our team had to weigh and pre-select patients that would be appropriate for treatment. So our solution to this problem began with our planning. The oncology triad met to raise the potential cancer treatment delays that JHAH cancer patients and Qatif government would face. We collaborated with multiple JHAH divisions to ensure site access, medication preparation, EHR access, that infection control precautions were implemented, and that supply chain issues were addressed. We formed a team and we created an effective action plan. We went on to implement the plan where, number one, we formed a team of JHAH staff to operate a remote chemotherapy clinic from Dhahran, as well as within the lockdown area. We then gained approval for Qatif site access, which was approved from MOH and MOI. We located a safe facility to deliver our treatments. We collaborated extensively with JHAH pharmacy and supply chain on medication preparation and delivery. We monitored our process and met daily to overcome challenges that were faced, and we reported our progress to JHAH leadership. This is just an example of our process map of everything that was detailed, of identifying a patient that was for treatment, going through reviewing of their protocols, approving their protocols, having JHAH pharmacy mix the medications in advance, and coordinating with the supply chain on the delivery of the medication before we can actually administer to the patient themselves. Just for time's sakes, I won't go through every step of this, but you can see it was quite an extensive process that we had to come up with to meet this challenge. I'd like to introduce you to the Al-Zahra Clinic and our JHAH team that was there. So this is Al-Zahra General Hospital, and here's a few pictures of some of our core team members. The Al-Zahra Clinic is located in Qatif, was a site for our JHAH remote chemotherapy clinic. It consisted of a 4-bed makeshift chemo area that would be manned by our team. Our initial team began with JHAH oncology staff, which included 1 consultant hematologist, medical oncologist, 4 certified oncology nurses, one of which was a nurse educator and very beneficial for helping pass that added family education on potential chemotherapy side effects, an oncology clinical pharmacist, and a phlebotomist. By the end of the clinic's operation, multiple JHAH staff under Qatif lockdown joined the initial team. Various allied health, pain management nurses, many individuals from the JHAH community were willing to step up and help their community out during this difficult time. I think at this point in time, I'd really like to send our oncology triads appreciation for everybody that was involved with making the Al-Zahra Clinic work. It not only demonstrated JHAH's core mission and values, it demonstrated more on a human, community sense, where those people were willing to step up inside an unknown pandemic time, put themselves at risk for the betterment of their community. So going over the outcome of our project, it's my pleasure to say that as a result of JHAH's collaborative efforts, a total of 116 JHAH cancer patients with solid and hematological malignancies on active treatment were served at Al-Zahra during this time, just between March to April 2020. Here's a breakdown of people that were on chemotherapy, immunotherapy, hormonal therapy, supportive therapy, palliative therapy, radiotherapy, and our total here of 116. Secondly, every one of those patients still was included within our oncology treatment center's Prescreening patient satisfaction reports. And during this time of uncertainty, we were able to maintain patient satisfaction scores of greater than 92%. We also demonstrated multidisciplinary coordination between JHAH services to achieve patient safety outcomes. And I think that this is, one of the nice things about being a collective group is that we're able to not work in silos, that we communicate with other departments so that we can better, successfully treat our patients. And in the words of Vince Lombardi, I found this quote to be really fitting, is that the achievements of an organization are the results of the combined effort of each individual. These are just some pictures here. We had a nice little article review from Dr. Nafisa, she's the chair of the Oncology Institute in the Arabian Sun, and we decided to publish this work in the Open Access Journal of Oncology and Medicine. So the link is over here if anybody is interested to read that. And at this time, again, I would like to really send our grateful appreciation to Pharmacy Services, Dr. Mohammed Al-Ghamdi, Government Services, HR, and especially the JHAH leadership. And now I can leave the floor open to any questions if there are any.
Thank you, Mr. Sharp, for the nice presentation. I received no questions from our audience. However, I have a small comment. Maybe we can share thoughts together. As you know, that the lockdown was a very difficult time everywhere, not only here at JHAH. Simultaneous multitude of safety issues were initially raised up, in particular those concerning patients with recent or ongoing oncologic diagnosis. They were very worried about harmful delays of their medical and or surgical treatment. So I understand from your presentation that you did very well in managing those patients, and you moved your treatment to the community away from the hospital session. And I salute you for that decision and that part of the leadership. May you comment on this as well?
Thank you very much for those kind comments. It was COVID being itself was a very uncertain time, and especially dealing with patients that have cancer, and that's a treatment that we can't really cease. We got to continue on with the effective treatment to be able to ensure that they have a higher chance of survival and that curability is an option. We did try to go through the Saudi Cancer Society's most recommended guidelines, which were being developed at that time. We were lucky to have Dr. Majid Othman be a part of that group and help create some of those protocols. Our big issue was, we faced an ethical dilemma of these patients that were located in this one area. Is it safe for them to delay treatment care for potentially longer than 30 days? And initially we were told is that, the Qatif was going to go under lockdown for a few weeks, and that extended for another month. And then what if it extended another month? And this not only our efforts to make this remote chemo center was beneficial for the patient so that they continue their treatment, but also it's beneficial to the organization itself. If we delayed treatment by 3 months of 116 cancer patients, what is the long-term effect of those patients? What is the long-term treatment for them? Will their chronic conditions develop further, and will we have to invest more of our resources to then treat them later on? Or if we were able to treat them later on. So I really appreciate everybody's JHAH leadership in their decision to give us some autonomy in getting this up and running. The Saudi Aramco giving us resources to get this up and running. The MOH and MOI giving us some of those leeways so that we can open up in such a quick amount of time. From the beginning until we opened up on day one was 8 days. And I think this is a remarkable feat of what can be accomplished when a collective group puts every effort towards it.
Congratulations, that was a great success.
Thank you very much.
Thank you, Joshua. And now we'll move to our next speaker, Dr. Ahmed Al-Almai. Dr. Al-Almai is one of our prominent Johns Hopkins Aramco healthcare psychiatrists. He's addressing the pandemic impact on the healthcare staff with the title of his presentation, Psychological Effects of Quarantine and a Pandemic on Healthcare Workers. Please join me in welcoming Dr. Al-Almai to the podium.
Thank you very much. Assalamu alaikum. I'll be doing a bit of a change of pace here. We're talking about slightly different topic here. I'll be talking about safety, although I'll be talking about psychological aspects of our practice. And let's see here, can I change those? Okay, here we go. I think that's okay. So let me see here. The last 2 years or so of the pandemic has not been easy for many of us. I would say that hasn't been particularly easy for many of our patients. I've seen more patients who never had any psychological problems, never had any anxiety. I've never seen them in my life came during this period of time. Now, that has been very tough. Why? Because during that time, rightly so, many of the resources have been directed towards, things to manage COVID-19. And there has been less effort and services directed towards our psychiatric patients, which are unfortunate for a while. But some of the anxieties, and I'll be focusing a little bit about the anxiety here, have been much higher than it has been ever. And a lot of it has to do with everything to do around the COVID-19. And a lot of it has to do with the media, social media outlets. And many of us have seen all kinds of crazy things come out in the social media during pandemics. Pandemics time is prime time for rumors, false information. There's a lot of people on their agenda that they take advantage of this time to spread rumors for whatever reasons they had. Now, one particular rumor is we see and we still do, the numbers of cases. Thank God the numbers of cases here in Saudi Arabia have been much lower than we've seen before, and we're able to get out of our houses and do stuff. That's not the case everywhere. And there's been lately a lot of rumors about the vaccination. Now, I would assume many of us here had the vaccination. I've had my AstraZeneca vaccination 2 days ago. Now, we've heard that many countries in Europe have suspended administering the vaccine because there's been some cases of strokes. Well, I'm still standing here before you, and there's no strokes, and thankfully I'm doing well, alhamdulillah. So, and I try to do my part of educating the public around the rumors, how do you manage anxiety, so forth and forth, in my weekly articles in Al Jazeera and Saudi newspaper and the Mecca newspaper. But talking about anxiety in general, generally the anxiety, the prevalence is somewhere around 20 to 25% worldwide. There's more females who are affected by anxiety than males. Generally, the symptoms tend to be about 43% symptoms tend to be mild. About 1/3 of that tend to be moderate, and the rest is 23% tend to be severe, that certainly need treatment with both psychological intervention and medications. Now, according to the Saudi National Mental Health Survey, it coincides with the many of the international papers, and about 25% prevalence for all anxiety disorders. That include all the anxiety disorders would include things like separation anxiety, social anxiety, post-traumatic stress disorder, generalized anxiety, and panic disorder. Now, is anxiety normal? The answer is yes. We do have anxiety on a daily basis. We do have anxiety around many things, tasks that we need to accomplish, deadlines, kids at school that they have to take exams, and they have to have some anxiety, the adrenaline rush that give us the performance so we can accomplish our goals. Now, what I want to point out here is the neurotransmitters involved with anxiety. Here I would see at the top left side on my slide would be serotonin, dopamine, and norepinephrine, and I'm not going into the mechanism or details, but generally when you see fears, remember back in high school we learned about the fight, flight, fright reaction. So when we see danger, we perceive that as danger. That signal goes into our amygdala, which is where memories are kept. And that gives us the idea that, okay, this is something dangerous, risky, we have to run away. That goes to processing, and from our cortex down to our muscles that get tense, and we have to get ready, either to fight or flight, run away. So that's normal, a normal process. And we see that every day, and that's not what I'm talking about. I'm talking about pathological anxiety, and I'll come back to talk about this, what kind of pathological anxiety that causes problems. Now, why do people have anxiety? Why do people have anxiety as a disease? Well, many times, as many in psychiatric disorders, as many of the medical disorders that we see, genetics have a lot to do with it. And yes, that we see that with the genetic familial component of psychological disorders is very important. But that's not enough explanation, because there's always an interaction between, genetics and environment. And there's something new evidence that talks about epigenetics. There's genetic mutation that can contribute to this as well. And we've seen that in many disorders such as autism. Now, anxiety disorders that we can see here, these are all the anxiety disorders that fall under the anxiety, and this could start from very young age. Age 6 months, babies have what we call stranger anxiety, and they cry when they see someone stranger that they don't recognize. But also separation anxiety when they start school, it is a form of anxiety. And the list goes on, but many of us have fears, children have fears of dark, insects, animals, etc., etc. But adults have fears of they have anxiety, what we call generalized anxiety, PTSD, when they're traumatized for some reason. And we've certainly seen a lot of traumas during this pandemic of COVID-19, and we've seen a lot of that. Now, one thing common between all of these anxiety disorders is there is the excessive worrying. People tend to worry too much, tension, and there was no shortage of that during this COVID-19 pandemic. One other important aspects of the anxiety disorders, and many times that we have somatic aspects of that anxiety. Why? Such as headaches, tension headaches, irritable bowel syndrome. Many of us have that. Now, a lot of these complaint symptoms can, many times, anxiety is a major component to that. And a lot of times when we treat the anxiety, a lot of these symptoms go away, simply. But that's not the whole story. Now, there are other aspects of many medical disorders, and when they're accompanied by anxiety, then the symptoms are exaggerated and makes it much harder to manage. So it's really important to focus on this so we can manage other medical conditions. Now, I'll give you an example of some of the common aspects of catastrophic thinking, and I've certainly seen a lot of that during my time volunteering at the JHAH created COVID-19 call center, which was a totally brand new experience for me and many of my colleagues, and I'll come back to that. But some of the calls we have received during that time would be someone who would start by calling and say, I have a sore throat. And when I had this sore throat, I thought, okay, this sore throat, I think during that time, everybody had symptoms of flu or cold or sore throat. The first thing that comes to mind is what? Corona, COVID-19, but then they're going to say I have the flu. And from there, I said, I have sore throat. I think this might be Corona. And next thing they say, my wife has fever or she has cough. I probably gave it to her. Then they say, my co-workers have some symptoms. I probably gave it to them. I gave the infection to my family and coworkers, and they all have the infection. Everybody is sick, and they're going to die because of that. Now, that goes from a simple sore throat, who probably will resolve in a few hours with no complications, into a major incident that this particular person thinks that he had corona, and he gave it to everyone around them, and the anxiety continues, and this is a kind of catastrophic thinking that we have seen. Now, we've seen a lot of research that was published within the last 2 years or so, focusing on COVID-19 and different aspects of COVID-19. And some of these papers, like all of you remember, many of the papers that have been published, like the medication, the hydrochloroquine, anti-malaria medication, and it was published in reputable, prestigious journals like the Nature. You know, a few months later, it was retracted. There was an oversight. How do you think people in the medical profession feel? Not very well. Well, there's a lot of uncertainties about this time. And me and some of my colleagues from around the world have contributed to this qualitative paper we published in the Child Adolescent Psychiatry and Mental Health. That was actually published last month. And this narrative that I put in, and it was about my experience at the COVID-19 call center. And I said, I was part of a group of physicians from different specialties who volunteered to cover the newly established COVID-19 call center to handle calls from patients, families, and other physicians and healthcare staff working in remote areas. This was a brand new experience for all of this group, most of whom had never handled this type of patient before, but now had to deal with the flood of calls to make quick decisions to handle cases as best as we could while working in a crisis mode. Now, many of us, and those of you who were working with me in the COVID-19 call center, remember recommendations change from day to day, and they still do. And that, contributed to that uncertainties. But again, there was a massive number of papers that was published during that time, and that all of that as well, including some of these papers published in prestigious journals, did not help the anxiety and the certainties around the COVID-19. Now, for us healthcare workers, in particular, that's been a major problem. Well, caused some anxiety. I wouldn't call it a major problem because many of us managed to do fine during that time, and we're standing here. But there was a lot of uncertainties about the COVID-19. Why? Because many of us had a danger, risk of getting the infection ourselves or some of our coworkers or even families. Now, I remember during that time when I used to come home from the hospital, and the first thing I would do, we had this room that looks like a sanitation room. I will take all of my clothes off, wash myself completely before I can actually go and hold my, my child and talk to my family. And many of us had to go to do this for months at a time. Thank God we're not doing that anymore, but we still have to be very careful. Many of us had family, colleagues, friends who contracted the infection. I contracted the infection myself in August of last year. Thank God it was mild symptoms, and I was quarantined for 2 weeks, and I was fine after that, no complications. There was home quarantine. Many of us had to take that home quarantine. We couldn't go anywhere. Now, that was a very stressful time for a lot of the families. Many of the expats could not travel during that time, okay? There was economic crisis. Many people lost their jobs during that time. And there was, particularly for us, healthcare workers with jobs that have heavy emotional demands. That certainly applies to us. Then there's all those of us who have to work shift works. That has added stress in many of us. Now, what people do, some of us, what happens is the stress takes its toll on many people. So what happens is they show some funny symptoms and funny behaviors, such as being rude, bossy, aggressive. You might say some people might start bullying each other, staff bullying each other, which is unusual behavior that we've never seen before. Some of them might have problems with focusing, concentrating, memorizing things that they're supposed to do, which is something they've done years, but they now struggle to remember what they are supposed to do. The judgment in some instances are impaired. Many of us have problems with sleep. They come to work next day and they can't focus on what they do and memorize what they're supposed to do. Some of the staff are becoming sarcastic, pessimistic. They feel incompetent at doing their jobs. They're irritable, you can't talk to, moody, and some of them might resort to smoking, drinking, or drink a lot of caffeine during that time, which caused a lot of problems. Now, I reviewed with you some of the behaviors, symptoms, some of the issues that we've seen during that time. What do we do to treat this anxiety that we've seen during this pandemic? First of all, we say to people simple things. Change your habits. Don't drink a lot of caffeine. People with anxiety tend to be very sensitive to caffeine-containing drinks or foods. So be careful. Normal people might drink a couple cups of coffee, no problems. But people with anxiety are very sensitive to caffeine. We need to educate people about this anxiety, what they do, and the bad habits. There's psychotherapy, and I focus on CBT, and there's pharmacotherapy. Caffeine here, watch where you're drinking caffeine, sodas, tea, coffee, drink decaf, don't drink any caffeine if you're one of those sensitive people to caffeine. There are some natural herbs, elements that could be helpful. A lot of people have B12 and folic acid deficiency that can contribute to depressive symptoms and some of the anxiety symptoms. There are some natural herbs and supplements that can help, like the SAMe and St. John's wort, Nabtat al-Qadis John. These are natural remedies that can be very helpful. Psychotherapies, there's a variety of psychotherapies can be very helpful. CBT, cognitive behavior therapy in particular, is one particular type of psychotherapy that is helpful in anxiety. There is DBT, EMDR for trauma, and there is family therapy. There are a lot of medications that we use. I'm not going to go into details, but SSRIs in particular, benzodiazepines, be careful because taking those can cause confusion, memory problems, especially younger or older population. But SSRIs are used, obviously, reserved for cases with severe anxiety. Overall, we have medical and psychological habits, and maybe some changes with their jobs can help with all of that. What do we do when we talk about a work environment? And I would say, direct my talk to managers, supervisors, provide safe, supportive work environment. This is really important. Staff have to feel safe coming to work. And there were times when people didn't feel that way, whether it was, different. And I've seen some of these examples, but make sure you provide safe environment. Make sure the work demands, responsibilities are reasonable, and promote positive work environment, okay? Don't get caught with the busy schedule and everything else. When there is changes, many of the people have their jobs changed during that time. Make sure you explain it and communicate to your staff well. And then I think this is my last slide. Make sure you manage stress very well. And one last suggestion, which we always use, is a sort of support group. Within your unit, have a dedicated time, 1 hour a week, where staff can meet by themselves in the absence of managers, where they can vent, talk about the stress, and communicate and support each other. This is really one important aspect of managing this anxiety. And this is my latest book about managing anxiety in times of pandemic. بالعربي هذا القلق. You can find it in Jarir bookstores. And this is where I would end. And I don't know if we have time for questions, but I will stop here. Thank you very much.
Thank you, Dr. Al-Mai, for this wonderful presentation. I have a comment, and maybe just asking for your input with that one. I didn't receive any questions from our audience. Of course, there is no doubt that the pandemic brought to us very stressful time. One of these challenges is the confusion of the measures that are rapidly instituted and policies changing every hour or every day. Certainly the staff, we are facing difficult time. In addition, that they need to keep with their patient care up to the standard. And we've seen actually on the care units, strange behaviors from both the staff and sometimes from the patients. They are a result of frustration, anger, and also reflection to the staff with their involvement with these strange behaviors. Do you advise any interventions for any similar future disaster?
Well, Saudi Aramco have asked us to prepare this what we call emotional support service that we have conducted a series of lecture symposiums and provided on-call extra hours for staff to come to us for counseling. So come and see us. Come for counseling. We do have the services available. Everything is confidential, but also the managers on the units. Watch your staff. Make sure you're not overloading them with work because they start to make mistakes. They start acting funny, and make sure they have time when they can meet with each other. Like I said, vent, discuss their stress with each other and support each other in the absence of supervisors and managers. Let them say what they want. Don't criticize them. They want to make sure that they can say what they want without being watched. So that's very important. So these are a few suggestions, but don't hesitate to come and see us. We're available for support and counseling. And, surface and treatment is simple. So,
thank you so much, Dr. Al-Amai.
Thank you. Thank you.
And it's time now to move to the next session.
Thank you very much. I do want to thank you all involved with the organization of this seminar, symposium, and to the leadership. Thank you for inviting me to speak. Appreciate it. Thanks.
Thank you, Dr. Al-Amai. Now we're moving with Dr. Bassem Fouta. He's one of the Johns Hopkins Aramco Healthcare Senior Certified Dietary Specialist. He's very well known for his enticing presentations, and he's talking to us today about strategic roles of clinical nutrition and food services in enhancing the health of care workers and patient safety and well-being during COVID-19 pandemic. Please join me in welcoming Dr. Bassem Fouta.
Good afternoon, ladies and gentlemen. It's really my pleasure to be with you in this great symposium that supports the patient safety, health, and well-being, as well as it would support the whole community for now and for future. My presentation is going to be on the food services strategies. So kindly, if the presentation can be presented. The slides. What's the next? Okay.
You can use your mouse to move the slides from your side, Dr. Fouta.
Okay. Where is it? Sorry. I thought somebody is organizing it.
It's there.
However, until it's opened, I'm going to speak about the food services strategies we have used at the JHAH Health Center that guided us into the serving safe, healthy, and well-balanced meals during COVID-19 pandemic. And I'll leave you at the end with some take-home messages. In fact, to start highlighting some aspects, the achievements we have done at JHAH Health Center Dietary Services is not only from our side. We got lots of support from infection control team, occupational medicine, risk management, and nursing staff in location 2. So that kind of collaboration made us stronger and made us better planner in dietary services. And this is really a great opportunity that we have invested in COVID-19 pandemic. The other aspect I'd like to highlight here that the food we serve to the, in fact, patients and staff here, we have considered too many factors. We have considered their ages, their, in fact, preferences, their culture, so it is most of person-centered and focus when we plan for all the meals. In my presentation, I'll highlight now on the burdens of the foodborne illnesses and the food safety as a public health priority. Then I will talk at
the most part of the presentation on about the food safety and quality management system that guided us to serve the meals in 2020 during the pandemic era. Food safety, ladies and gentlemen, is one of the major determinants for health and well-being for individuals as well as for the societies. Throughout the world, in fact, food services from food safety, it is considered as a public health issue that all the governmental, non-governmental parties, they will work, in fact, towards that goal. Let us please take ourselves into some aspects when it comes to food safety. We understand that unsafe food contains bacteria, viruses, other germs and chemicals, and causes more than 200 diseases all over. From the impact of that on lives, it affects more than 600 million people in the world, 1 out of 10. And how many die per year? 500,000. In fact, the people who die, in fact, from the food, let us say, aspects from poisoning point of view, they are vulnerable groups in which they have been affected mostly by COVID-19. From the loss of healthy life years per year, 33 million. So look please to the productivity, the impact on the economy, as well as the impact on lives. What else in this aspect? In fact, from economical impact, per year only for the low and middle income countries, more than $110 billion. I look to how much really the loss. CDC estimated that in the United States, 1 in 6 individuals, so 48 million people, they got sick because of food poisoning, and 128,000, they are admitted to the hospitals, and look into the loss also economy and loss of productivity and others, and 3,000 people, they die accordingly. When it comes to WHO reports, they said 220 million people they are getting, but from which category of age? Children. They are getting the food poisoning worldwide. 96,000 die per year. So this is another aspect how much really important for us to pay attention in food safety, and this is what we have done during 2020 pandemic for COVID-19. Because unsafe food, it creates a vicious cycle from diarrhea to malnutrition, lots of complications, and it affects, as we said, younger people, elder people, and persons with immune-compromised diseases and others. Those are the highly affected people, and beside the chronic illnesses. What are the foods, ladies and gentlemen, that are getting spoiled? Mostly any expired dairy, or even breads and others, undercooked or uncooked. And this is what we always avoid in here, that we need to make the cooking that is adequate and no undercooked, whether it's a meat or eggs or in any recipe. Back now to COVID-19 from food services aspects. What we have done in here, we have created a well-structured food safety quality management system that guided us in 2020 strongly. We had it earlier, but we in fact injected too much strength in it, and we got the consultations from, as I said, occupational medicine, infection control, risk management team that made it more of, I would say, multidisciplinary and implemented at the ground. So, in fact, it started with the vendors' selections, bringing the food in here, until the waste management. So 9 well-structured stages, and in each stage, it depends on the food mapping. So we call it food journey in this aspect. And in fact, you might ask us, what is the evidence for the effectiveness of JHAH food safety quality management system? Is no any incidents happened for food poisoning, though we have delivered 35,000 meals from Dahran Health Center to location 2 from March to September. This is a huge number of meals for staff and patients, but things went very, very well due to the well-structured food safety quality management system. The meals, I understand that we made it, let us say, healthy and safe, and we made it based on the person centers, ages, and medical conditions of the patients, but also we made it in fact, injected or more rich with the immunosupportive nutrients. Some of the nutrients the previous speaker talked about it, from B12 and iron, from protein and others, but also we eliminated any single nutrient or let us say food aspect that might affect the immunity negatively. This has been positively reflected on our customer satisfaction rate, and we have noticed when we started working on the meals from all these aspects, the Press-Ganey results showed the improvements from 75% and even reached to almost 80%. These are the 9 stages, ladies and gentlemen, what we call it food mapping, and we set the target 90%, but we always exceeded the target until even we achieved 97%. We have invested, honestly speaking, of this food service quality management system. We have applied to our international food safety certification from UK, and we got our food services facility here internationally certified by UCAS, and this is something positive, and they admired, in fact, what we have done in here, and it has been published by them. An important element in this food safety management system is what is called HACCP, hazard analysis. So the hazards are biological, chemical, physical, and allergenic. So we have identified the hazards in here, we put limits, then we go regularly and monitor these, and then we close the gaps, we validate, and we verify until we have reached really that much of elimination of the HACCP. Our kitchen, ladies and gentlemen, from food service facility point of view, is very well structured, too many areas. This eliminated the cross-contamination by having certain people, specific people working every single location in the kitchen, no any shared manpower, no shared tools and others, from, I would say, receiving to the cold kitchen, storage, hot kitchen, sanitation, delivery, and every single aspect. These are some of the stages, what we have done. So in each stage, from food mapping point of view, there is a designated area, designated tools, and there's tracer methodology, QI, in all these aspects. Let us please link all that to COVID-19 from a nutrition point of view. And I'll focus more on immunity, in fact, in nutrition. This system, ladies and gentlemen, made us, as I said, stronger and guided us to serve almost in 2020. We served 300,000 meals, 100,000 for medical staff, 200,000 meals for the patients at the Dahran Health Center, as well as at location 2. Made us like a center of training. Too many people from Aramco and outside came in here, and they learned from the, I would say, the practices we have implemented at the ground. And in fact, even GCI and I would say Sibahi, they in fact admired what we have done, especially for the meal specifications, for the cafeteria layout and others. So this is the standard. We got 90% our here benchmark, but we always exceeded it in 2019 and 2020 until we reached 97.5, and this is internationally. A challenge that we overcome when we started serving the meals location 2, we had sometimes 130 patients, 140 patients in there, and also for Ramadan it was a kind of a challenge as well. We have too many Muslims fast Ramadan, they need iftar and sahur, and non-Muslims, they need also other 3 meals. So we integrated what we call it Seaboard Food Service Management System at Dahran Health Center with EPIC in there. So we knew our patients, if they have medical conditions, who's obese, who's hypertension, who is, I would say, from different culture, children, etc. So we planned the meals in there, and we enriched it with immune supportive system. We eliminated caffeine. We only allowed caffeine to be around 150 milligrams per day distributed, but not in the evening, though the caffeine recommendations up to 400 milligrams. So we made it by less than 60%. And I agree with Dr. Ahmed that excessive intake caffeine is not that good for immunity as well. We, in fact, educated the patients virtually, and we told them that immune system needs to be nourished, needs to be fed. By what? But by the immune supportive nutrients. So we need to boost the immune system, and the good thing about it, that when we boost immune system, we boost, in fact, the cardiac, and we boost the, let us say, the muscles, and we reduce the risk of many NCDs, such as hypertension, cardiac, obesity, and diabetes. So there is a very good benefit in here from the immune supportive nutrients. So we enrich the meals. We'll show you some samples in that. We enrich the meals with antioxidants, lots of it, vitamins and minerals. And for those obese individuals, we supported them to lose weight, but gradually. The other aspects in here, all the food that was served was safe. And so we did not allow junk food to go in there. We minimized the stress, and again, Dr. Ahmed highlighted in it. So we eliminated the sugar, and we limited the caffeine, and no junk food in here. And we managed, I would say, some of the stress and high oxidative, we call it oxidative stress, by serving lots of the food rich in antioxidants. We linked, when we educated the patients, we linked the cardiac meals to the immunosuppressive meals, because if the cardiac system is that strong, it can, in fact, deliver that much of oxygen and nutrients, bloods and water from hydration point of view to all the organs, including the lungs. So this was very well clarified to our, in fact, patients here and there. We served lots of protein in it, quality, high quality protein, and we in fact supported the GI of having the probiotics growing by the fiber and other fermented food. Around 25% of the patients been located in location 2 been diabetic, so we gave them diabetic meals, but modified Mediterranean diet plan, and they appreciated it. Those individuals with high blood pressure lipids also been provided with the appropriate food. As I said, all the processed food, sugar, etc., been eliminated. We were so clear, ladies and gentlemen, in our facility here, and even when we communicated with the patients and in our publications, that recovery from COVID-19 is not the end of the healthcare journey. There is further steps to be done in there. So there is inflammation, even low-grade inflammation goes on. It might cause clots in the arteries going to the lungs, to the brain, and to the heart. So we continued having that kind of meal plan presented well to be cardiac and, in fact, to reduce the risk of inflammation, as well as from the oxidative stress, and supported the respiratory, circulatory nervous system to reduce the clots in here. So we've been, in fact, so strong in here, and Saudi Aramco asked us our help, so we supported Saudi Aramco from all food service facility at that time, and even our cafeteria here, again, thanks to all multidisciplinary teams that supported us. It was highlighted positively. We encouraged the takeaway, etc. My last slide here, ladies and gentlemen, explains how is the meal plan we have prepared here for the Health Center in patients, our staff as well, because they are our customers. We supported the health, well-being, immunity for the medical staff in here by their food, coupons, etc., as well as for the medical staff who've been in location 2. Here we see the dairy products. So we have here vitamin D, we have here also high-quality protein. We have the water for hydration. We have here some B vitamins, B12 and others, and as well as B vitamins in here, B12. And we fed here the GI microflora, protein, high quality protein. It's almost 1.5 grams for some of the patients. We provided more fruits and vegetables in regards to the antioxidants, vitamins, and minerals. So we made it person-centered, but science-based, evidence-based, based on the latest guidelines, supported the immunity and supported as well as the heart care, brain care, lungs, etc. Again, my last word here, that really COVID-19 pandemic, ladies and gentlemen, made us stronger and made us better planner in food services. Thank you for giving us the opportunity to share all these guidelines with you. And I'll be glad to receive any questions.
Thank you, Dr. Futa. It was a wonderful talk, and good job by the Dietary and Nutrition Services. Thank you all. I don't have any questions from our audience.
Thank you very much.
All right, so we will now be going to Baltimore to be joined by Dr. Albert Wu. We all remember him from his talk on the first day. Dr. Wu is the Director of Center for Health Services and Outcome Research, Joint Appointment in Medicine at Johns Hopkins Medical. The title of today's presentation is Supporting the Well-Being of Health Workers During the COVID-19 Pandemic. Please join me in welcoming Dr. Wu. Dr. Wu, you may unmute your microphone.
Thank you so much. Well, I'm indeed honored to be presenting on this topic to this important meeting. And I think there has never been a year when talking about supporting the well-being of health workers has been more important. The picture I'm showing is a picture from very early in the pandemic. This was a scene from New York City. And every evening at 7 p.m., people who were confined to their homes would gather at their windows, on their balconies, and they would applaud. They would cheer, and they would ring bells and sometimes play instruments and bang on drums to celebrate and to thank healthcare workers. Those days seem very far away. And I think that at this very moment, there is much less public support, much less obvious public support for workers, which does not make things easier. The objective of this presentation is for the audience to be able to describe the impact of COVID-19 on health workers. We have already heard this. Explain the phases of emotional response to any disaster. List 3 kinds of support needed by health workers, and describe 3 things you can do to support your colleagues and yourself during the pandemic. I think that superheroes are probably as popular with children in the kingdom as they are in the US. This picture on the right shows an assemblage of superheroes who are welcoming the doctor and the nurse to the ranks of superheroes, because indeed, by rushing forward to take care of patients, even though there was personal danger, they were displaying real heroism. And the cartoon by Banksy shows a child who's discarded his superhero dolls in favor of a doll of a nurse. At Johns Hopkins Hospital in Baltimore, this is a photo of our precision flyers from the Navy, the Blue Angels, flying over the hospital to thank workers for the work they're doing in April of 2020. But even by the time April came around, a month into the pandemic, people began to wonder, are we done yet? This is a communication. Charlie is a little boy who says, "What day is it?" Mom, "Tuesday." Charlie, "Is there still a coronavirus?" Mom, "Yes." Charlie, "Okay." We've all been waiting for the past year for the answer to be no, we're done. In the meantime, COVID-19 has weighed heavily on all of our societies. This is a picture of Times Square, normally full. This is the city that never sleeps. Times Square is always full of traffic, of people, of tourists. On this day, in April of 2020, it's virtually empty. The pandemic has hit the US very hard, harder than any nation, ironically. There have been 29 million cases documented and over 500,000 deaths. And perhaps importantly, if you look at the orange bars here, the total area shows all ICU beds across time. And just in the past couple of months, from December until February, nearly the majority of ICU beds were filled by COVID patients, as opposed to all other intensive care patients. This put an extra amount of staff onto workers who needed to work more slowly, more carefully, and more fearfully, honestly. The impact of the virus has been profound on the mental health of hospital workers worldwide. This is from a meta-analysis published late in 2020, and it shows the prevalence in percent of depression, anxiety, acute stress reactions, post-traumatic stress disorder, insomnia, and early work burnout. The prevalence is up to 44% in some countries reporting. And the risk factors are not surprising. They include the direct exposure to the virus, working with patients with COVID, being a nurse, or being any kind of frontline worker. Reporting low social support and perhaps less work experience. And these last two are not surprising. This is quite a prevalent issue in the kingdom, where many workers are from other countries and who are separated from their families. They've come to seek their fortunes in the kingdom, where there is good work and good pay, but they are separated from their social networks, from their families. Not everyone speaks their native language, and it's more difficult for them. The younger staff have routinely, on average, reported greater distress. Perhaps they're not as hardened, they're not as toughened as some of us who are a bit older and who've experienced more in our lives. Perhaps I shouldn't show a photograph of a candy machine after our very nice presentation about nutrition, but I think this presents a really great analogy. This shows a candy machine, which is functioning, but not functioning perfectly. The sign says, "The light inside is broken, but I still work." And someone commented on Twitter, "A better definition of burnout I have yet to read." Health workers are crippled a little bit, but they're still working. When we asked the question to one of our workers, "How are you coping?" he said, "I'm not coping. I'm just surviving." The extra pressure on workers poses a risk to the mission of all of our organizations, because distress can be disabling. People do not perform up to their usual standards. They may need to call out. There have been workers that I've spoken to who've said that they've been unable to come to work for weeks at a time because they're just afraid. They just can't even get out of bed. Recently, there's been increased turnover. At the very peak of the pandemic, when in particular nurses and ICU nurses were in terrifically high demand, we lost nurses who went to work for traveling nurse services that paid 3 times more sometimes than we were able to do. This creates a threat to the COVID response. People are required to work mandatory overtime. They are more tired, more upset, and less able to do all the things that are set in front of them. And perhaps in some ways, they have less personal compassion that they can give to their patients, something which is so important, particularly when those patients are in their own families. And the nurses and the doctors are perhaps the only support that those patients have. It turns out there is a predictable pattern of emotional response to disasters of all kinds. This graph was prepared and modified from work by Zunin and Myers from the 1990s by Dr. George Everly and our team. And it shows the emotional highs and the emotional lows that one can expect during a pandemic. There are several phases that people typically go through, whether it is a pandemic, a hurricane, a tsunami, an earthquake, a fire. Initially, there's the first phase is the initial impact. At that time, there's panic, confusion, and people try to preserve themselves. They try to save themselves, and they tend to be skeptical of authority. They tend to be less likely to follow leaders. This perhaps was waiting for COVID patients to arrive in the hospitals, and when they first arrived, there were people who had panic attacks. The next phase, however, is a heroic phase. There's a high level of anxiety, a lot of people running on adrenaline. People rush forward to try to help. They work together, and in most cases, they find that they're able to do more. They make new connections, they bond, they have some purposeful work to do, and they become optimistic. In fact, there's often a peak, a honeymoon, when community cohesion is maximized, people feel new relationships and are optimistic. But this happened in Baltimore perhaps in April or May. People began to say, we can do this safely, and we're doing the best we possibly could. Thereafter, begins a long phase of disillusionment. People begin to realize that resources are limited. They face their own constraints and their own discouraging experiences outside of the hospital. People may shun them, or they may be stigmatized because they're worried that they may spread infection. People then begin to cope in maladaptive ways. This is where people become really depressed. This is when there begin to be suicides. People may turn to mood-altering substances, alcohol, drugs, and they begin to feel abandoned. This is when people begin to say, we're not heroes anymore. People are not treating us like heroes anymore. And we are now in this long phase where life in society seems to be resuming, but workers are still working as hard as they ever have in the hospital, in the ICUs, taking care of dying patients. We are going to be here for a while, which is why it is so important that we attend to the mental health of our workers. We've been fortunate at Johns Hopkins in Baltimore and Maryland that healthcare well-being has been what we call a red ball issue for the entire pandemic. From the point of view of leadership, from the point of view of those who run our Unified Incident Command Center. Dr. Lisa Maragakis, who you have heard from and will hear from again, is our lead commander and has been one of the most conscious of this need. A red ball is a term used in aviation to identify aircraft maintenance issues. If a red ball is detected, that means that this issue could prevent a plane from flying, or worse, it could prevent it from flying after it has already taken off. Obviously, this is crucially important to deal with. And every day in the command center, we review the red ball issues that we must confront at the end of the meeting until the next day. For many, many months, health worker well-being and resilience were the #1 red ball issue for the Johns Hopkins Medicine COVID-19 Incident Command Center. And at the beginning of every meeting, Dr. Maragakis and her other commanders begin the meeting by asking first, have there been any safety issues in the health system for patients, for workers? And can someone report to us about the well-being of our staff? How many encounters have we had to support those workers? And what are issues that people are talking about that we need to address? It's important to have health care services. It's also important to have mental health services. And Johns Hopkins, for the first time this past year, developed a real integrated set of staff support services. We've always had quite a few support teams. There is a whole office of well-being in the hospital for the health system. They include some health promotion activities, which include exercise and diet. That's called Healthy at Hopkins. There is a spiritual care and chaplains department. These are multi-denominational individuals who can support people from any religion. RISE, our Resilience in Stressful Events program, I will tell you a bit more about, but it's a peer support program. My support is the Employee Assistance Program for all staff and students for that matter. And of course, we have quite a reputable Department of Psychiatry. These groups had always functioned a little bit independently, but in March of last year, we began to work together. We were asked to meet and coordinate our services, determine what the need was, adapt our services and develop new services, and also work together to coordinate so we have a continuum of services. If someone simply needs help with health promotion, that would be fine, but they might be referred for psychological first aid from RISE. They might need brief counseling from my support, or they might really need medical care for their mental health problems from psychiatry. We created a group called MESH, Mental, Emotional, and Spiritual Help. These are some of those leaders. They include the top leaders in each of those departments. And we thought about Maslow's hierarchy of needs. There are basic needs, psychological needs, and self-fulfillment needs that we all have all of the time. Some of our basic needs are for meeting physiologic needs and safety. Of course, we need food and clean food and water. We need rest. And sometimes those things were really in short supply for workers during the pandemic. We, of course, need safety. We've been very fortunate at Johns Hopkins, but and having adequate personal protective equipment. But we've heard many stories of workers who are working under unsafe conditions and becoming infected as they're attending to their very sick patients. We then have psychological needs. We need to belong. We need, if we're feeling distress, we need to be supported. And we have needs to feel like we are doing things. We need to actually be fulfilled in our work. That is why many of us are in healthcare. We need to feel like we are doing something, we are creating, we are moving forward. And this, again, can sometimes be in short supply during the last year. One thing which was very important to us was that we not only have the services, but that people know that they existed and be willing to use them. And it's much more difficult to simply have a service. It's much more difficult to implement that service and to make sure it is accessible and actually used by people. One program which we have been running now for almost 10 years is RISE, which stands for Resilience in Stressful Events. This is a peer support program run entirely by volunteers. At the beginning of the pandemic, we had 35 volunteer health workers of all disciplines, nurses, doctors, social workers, chaplains, emergency health workers, physical therapists, others. The one thing they had in common was that they were very good at listening. These are the people who people naturally go to when they need to talk to someone. We train them in psychological first aid and peer support, and they work 24 hours a day on call to provide confidential support. We take calls through a paging system or by phone. And initially, before the pandemic, we did all of our support virtually in person. But of course, there's more need for virtual support now, and we have supported more groups using Zoom or other remote methods. We've also begun to round proactively on the units that we know are busiest and where there is the best for. If a unit is being converted from a regular unit to a COVID unit, you know that people are going to be worried and concerned. When a patient was initially thought to be COVID negative, but then after some time converted to being COVID positive again, we knew that there was distress. We worked closely with our hospital epidemiology and infection control team, and I think this was a real novelty and an innovation. We knew that sometimes the directives that infection control put on people would be unsettling. People might be upset, they might push back, and they could use emotional support. We would take care of these encounters together. I think teaming up has helped us accept all of the sometimes rapidly changing procedures and protocols that we need to follow. We trained an additional 50 responders, and from March until December, RISE alone, among all of the services, supported over 3,000 individual staff. We did get some gratitude from our workers. This was a note that someone wrote: RISE has literally kept me and my teams alive for the last few months. There have, as you know, been suicides at other institutions. We, in fact, also have had people who've expressed suicidal ideation. Fortunately, nothing has been executed, but we do feel that this service has provided a great benefit and helped keep our workers safe and hence keeping our patients safe. Now, the interesting thing is that support is fractal. The same basic principles, the same basic needs at a group level are more or less the same at the individual level. So we can think about how can we support ourselves and our colleagues immediately at hand. We all, of course, have basic needs. And in order to take care of yourself, I think you need to, and this sounds silly, we need to make sure that we eat, drink, and sleep on a regular basis. While this seems trivial, people that I've talked to say that during their COVID shifts, sometimes they will not go to the bathroom for the entire shift because it's so much hassle to get in and out of all the protective equipment. People do not sleep enough, or they do not sleep well. During the peak of the pandemic, people had trouble getting food, or they would leave the hospital and drive around trying to find milk or toilet paper for that matter. It's important to give yourself a break. And we mean that in both senses of the word. One is to take a break and do something that you enjoy. What is something that you have typically enjoyed doing in your life before? If it's dancing, if it's walking in nature, if it's sitting in a bathtub, you should do some of those things sometimes. You should also not be so hard on yourself. You should understand that it is just not so easy. Getting exercise can perhaps be one of the most functional things you can do for yourself. This somewhat scientific diagram shows how much I'm able to get done on the vertical axis normally, quite a bit, and during an unprecedented global crisis, perhaps not quite so much. It's important to give yourself a break, to appreciate this is where we all are. It's not so easy. To attend to your own psychological needs, well, we are doing that in some ways right now. I think that Zoom has actually been, and all of its sisters and cousins have been a great benefit to people and family who've been able to reach out to friends and contact them and see them and interact with them, even though they can't perhaps see them in person. Reaching out to friends is very important, and perhaps taking extra efforts to do that. A strategy which has been very useful for some of our younger workers who are separated from their colleagues. They've recently just been training in cohorts that they were very close to, and now they've separated and gone off to different institutions. Buddying up, finding someone to pair with and to contact daily, just to check in. I was talking to an intern who said that she contacts one of her friends from medical school every day, twice a day, and says, how are you? Are you okay? Do you need anything? Would you like to talk? Checking in with yourself is something that we often do not do. It's the patient who needs the help, obviously, right? Not yourself. But checking in with yourself is something that we can all do. Just get up in the morning and honestly say to yourself, how are you doing? How are you feeling? Is there anything you need? If so, it's perfectly reasonable and, in fact, the right thing to do to ask for it. There's this myth that only the weak ask for help, but in fact, it's really the strong who are strong enough to recognize that they need help and seek it so that they continue to be strong. Psychological first aid is a technique that I believe should be the next CPR. We should all be trained in psychological first aid. Dr. George Everly at Johns Hopkins has developed a psychological first aid MOOC on Coursera, a free online course on how to do psychological first aid. He indeed was one of the developers and initial inventors of psychological first aid 30 years ago. And his course is on rapid first aid, which in truth is largely listening empathetically. Since the beginning of the pandemic, this course has become very popular. Scientific American, the magazine Scientific American, reported on this and said, we believe everyone should take this course. And in fact, several million individuals have visited the page, and 300,000 people have enrolled in the course in the past 12 months. It's free. I think that trying to be positive and also trying to avoid the negative is something else that we can do. Limiting exposure to disturbing media has been something that I personally have found to be helpful. We just sometimes need to turn off our devices. We also can try to be more constructive. In general, we are all critical thinkers, but sometimes we can be a little bit too critical to our colleagues. When giving advice, I think trying to give constructive advice and criticism is something we should strive for. We should all listen more, particularly if you are a leader. You should be listening more before you talk, and then make sure you respond to what you hear. Having a somewhat open agenda for part of your meeting is also something that is a strategy. And we can always compliment and encourage our workers. It never hurts to compliment someone. It doesn't cost anything to us, and it really makes people feel good. Even if it seems silly and trivial to you, no one who is complimented actually says, oh, that's silly. They feel good. Try to be a little bit more kind than usual. And if someone gives you a little bit of attitude, or you hear something from them that you actually don't love, you could just say, you know, I think it's been difficult. It's been difficult for all of us, hasn't it? This slide shows the value of an act of kindness. The vertical axis, a little versus a lot. The amount of effort it takes to be kind, not so much. The impact it can have a great deal of impact. We do need to feel fulfilled. I think it is remarkable what we have done together in the past year. I think it's worth taking time to reflect and to honor your own service, to recognize your colleagues, but to recognize what we have all done together in our many disciplines. In the last year, we have discovered that we have more colleagues on the front line than perhaps we were aware of. People who are working in nutrition, in security, people who are reconstructing and rebuilding our hospitals and rooms so that we can take care of patients. People who are cleaning, people who are doing the laundry. They've all been absolutely essential in disinfecting our units. These are all frontline workers, and together we have accomplished a great deal. I think we should remind each others and ourselves that we are part of a long legacy of excellence and compassion, and we have done a great service to our society. In summary,
Dr. Wu, we have
caring
questions.
for
We allow
COVID-19
2 minutes,
patients,
please.
Staff care with COVID-19 patients are understandably anxious, fearful, off balance, and missing their networks. This has led to confusion at times, real grief at the number of people dying, anger at people who perhaps are not providing enough support, and real exhaustion.
Dr. Wu, can we move to questions and answers?
Oh, absolutely. In any event, I think that we can all employ strategies to meet our own needs, and this is our chance to make things better. There are references available, and I'm happy to contact anyone in the future.
Thank you, Dr. Wu. It is a wonderful and entertaining presentation. I have a question from one of our audience, Mr. or Dr. Bahab Sisu. Is asking you, what kind of challenges did you encounter in running your program during this period? Also, what strategies did you use to overcome them?
This is a great question. One problem that we had was that even though we had such a range of wonderful services, still the minority of people used them. We knew more people needed our service than were getting it. And so what we tried to do was to reach out to those groups that we thought in particular were not using services. For example, we began to roam around the hospital. We began to round regularly in the sub-base mental services staff, and these are people who most never called for help, but in fact they were expressing a lot of distress. We went to our security guards who were confronting people who wouldn't wear masks and who were very upset, and we went to their lineup that they did every day, and we told them that we were there and gave them information and offered to talk to them right on the spot. So we reached out further and we blanketed the institution with messages on our plasma screens, in flyers. Our top leaders also would say, it's natural to need help right now. I, in fact, myself have been feeling anxious, even though I'm not an anxious person. You should call RISE. You should use our mesh services. They can help us all do a better job.
Thank you, Dr. Wu. That was great entertainment and answering for our questions. I will beg your pardon to move to our next speaker, also from Baltimore. That is Mrs. Wilma Behrens. She is the clinical nurse consultant at Johns Hopkins Medicine International. Wilma is talking today about patient and family-centered care. Is it possible during a pandemic? Please join me in welcoming Ms. Behrens.
Good afternoon, everybody. It's quite an honor to be with you. And I have to say, as you heard, I'm in the United States, so I had to get up early to enjoy all the sessions, but I have to say it was definitely worth it. So I am going to talk to you about patient and family-centered care and ask the question, or if it's still possible during a pandemic. The objectives for today's talk are to define patient and family-centered care, to explain Plaintree's guidelines to preserve family presence during the pandemic, understand the Johns Hopkins visitation policies during this pandemic, and you would be able to, at the end of the presentation, state innovative and creative measures to allow for person-centered care. Before we go into the part of the COVID-19 pandemic, I want to briefly review what patient and family-centered care is. So it's an approach to the planning, delivery, and evaluation of healthcare that is grounded in mutually beneficial partnerships among healthcare providers, patients, and families. And it's an approach that shapes policies, programs, facility design, and staff day-to-day interactions. Patients and families are forced into a foreign environment and culture that can be intimidating, overwhelming, and perceived as unwelcoming. Families, especially those in critical care areas, are at one of the worst moments in their lives and suffer from an extreme level of stress, where they may feel powerless and out of control. This level of stress creates short and long-term consequences, as many patients and families face severe emotional distress, which may result in post-traumatic stress disorder. In order to mitigate the severity of the stress response from being in a hospital and optimize the quality of medical care provided, patient and family-centered care is a philosophy that highlights the importance of including the patient, when possible, and family in the provision of healthcare. According to numerous studies, patients and families directly benefit from the incorporation of the fundamental principles into practice. Patients and families have reduced anxiety, better cooperation, improved satisfaction, reduced emotional distress, better adjustment to hospitalization, and faster recovery from illness and surgery. Because the needs of families are addressed more explicitly, Families also have improved functioning, increased confidence in providing ongoing care to their loved one. They have a greater willingness to seek help from healthcare providers, a greater degree of trust, and improved competence in problem solving and making complicated healthcare decisions. Healthcare providers, institutions, and the healthcare system also have a direct benefit from patient and family-centered care. When they gain important insight into the needs and values of patients and their families, they establish trusting relationship and improve the quality, efficiency, and safety of the care they provide. As a result, providers have improved work satisfaction, which leads to improved job performance, reduced burnout, and decreased staff turnover. With the provision of higher quality care, healthcare institutions and systems benefit with reduced healthcare costs, improved patient and family satisfaction, and reduced risk for litigation, and they potentially gain a more competitive position in the marketplace. So the Institute for Patient and Family-Centered Care has come up with the 4 concepts of patient and family care, and they are respect and dignity. This is where healthcare teams listen to and honor a patient and family's perspectives and choices. This is when you start forming the relationship and you offer choices to your patients and their families. You make them feel like they have control over their care, and you provide emotional support and relieve anxiety. You have to incorporate the knowledge, values, and beliefs and cultural backgrounds into the planning and delivery of care. Information sharing is the second concept. This is where healthcare practitioners communicate and share complete and unbiased information with patients and families in ways that are affirming and useful. Make sure they can understand you in lay terms. Patients and families have to receive timely, complete, and accurate information in order to effectively participate in care and decision-making. The third concept is participation. Patients and families are encouraged and supported in participating in care and decision-making at a level they choose, so where they are comfortable. This helps enhance independence and control. Now, this will vary from patient to patient. You might have patients who want to be very much involved in their care, but there might be others who are not that interested. It will also vary from family to family, and it can even vary from day to day. Depending on any physical or emotional factors, they might have competing responsibilities, so as other children at home that they have to take care of. So make sure you include them in a level that is comfortable for them. And the final concept is collaboration. Patients and families are included on an institution-wide basis. Healthcare leaders collaborate with patients and families in policy and program development, implementation and evaluation, healthcare facility design, professional education, and in the delivery of care. Here, patients and families are also part of certain committees, like the Service Excellence Committee, a committee for new hospital design or redesign, onboarding and hospital orientation, and policy meetings. Another organization concerned with patient and family-centered care is Plaintree, and this is their mission: inspiring caregivers to make patients true partners in their care, meeting their human needs and improving outcomes, personalizing, demystifying, and humanizing the patient experience. And according to Plaintree, person-centered care is based on 3 basic pillars: purpose, process, and practice. So in purpose, you unite your team around a shared mission. You empower staff with opportunities and responsibilities to personalize care, promoting continuity, consistency, accountability, and partnership with each patient and their loved ones. In process, you make your person-centered care systematized, achievable, and repeatable. You develop a comprehensive, formalized approach to engaging patients and their families in all aspects of care, tailored to the needs and strengths of the organization. Finally, in practice, you turn the person-centered goals into action. You involve your staff, your patients, and family in the design, implementation, and communication of your organization's improvement efforts, consistently assessing and prioritizing strategies over time. The essence of all this, of course, is patient quality and safe care. The right care in the right place at the right time. Care should be safe and well coordinated. And then, of course, we were hit with the pandemic, and we had to come up with new guidelines to balance the health and safety of our patients, their families, and staff members, which, of course, is everybody's top priority. And we have all seen the slides. The one on the top, you see Romanian women who recounted their traumatic pregnancies because they had to be alone delivering their babies. Residents were alone and in isolation. Those were the side effects of protecting the nurses in a home residence. Hospital bans on visit devastates families in the New York Times. And another consequence of the pandemic was that we saw a lot less people coming to the ED for myocardial infarctions and strokes, for example. And it was not that less people suffered those, but they were just too scared to come to the hospital. So how do we guard against regressing to a paternalistic we know best approach and continue engaging patients and family caregivers as partners while we are operating in crisis mode? Healthcare teams are working tirelessly under extreme difficult circumstances to provide optimal care for patients. Health authorities, health system executives, and clinicians have needed to be responsive and proactive amidst rapidly evolving, highly variable conditions. And as a result, many care settings have reassessed the customary approach to family presence in an attempt to find a balance between maintaining safety and supporting patients, families, and staff. It was necessary to introduce temporary measures for managing family presence in a way that supports the need for physical distancing and minimizing the risk of transmission. However, a pandemic does not necessarily minimize the importance of patient and family engagement. So in addition to weighing the risk of having visitors, healthcare institutions should also consider the risk of restrictions and what risk that may pose in the future. Just think about some once-in-a-lifetime events like the birth of a child or the end of life. Not having a support person can have devastating long-term emotional, psychological, and other health effects. So how can we minimize transmission and limit risk while building assurance that patients are safe in our care? We have to do that with compassion. Care delivered in a way that addresses not only physical and medical needs, but human needs for connection, support, and understanding. So we have to form a partnership with our families and patients. So we deliver the care with the patients and families, not merely to them or for them. So the Plaintree guidelines that they came up with for preserving family presence in challenging times was not only endorsed by the Joint Commission, but they also contributed to the development of these guidelines. Recommended by Plaintree International Coalition and co-developed by an international multi-stakeholder coalition, including patients, families, elder advocates, experts in quality and safety and infection control, clinicians, policymakers, and healthcare executives from a variety of different care settings. The Joint Commission met with our Patient and Family Advisory Council to express support for these guidelines and identify opportunities to collaborate with the coalition. And here are the guidelines that Plaintree developed for healthcare organization. The first one is assessing the need for restriction. And that could be to avoid transmission, but also in the beginning, it was to preserve personal protective equipment. You have to follow infection control guidelines, communicate both with staff and visitors ahead of any restrictions, so people know what to expect, and decide on exceptions, for example, in end-of-life situation, and use virtual means to minimize isolation. The second guideline is minimizing the risk of physical presence by following appropriate infection control guidelines issued by the World Health Organization and local and regional health authorities. Communicate what to expect proactively and with compassion so families do not appear at the facility unaware of restrictions that have been put into place. Establish and clearly state compassionate exceptions to family presence restrictions, for example, in end-of-life situation. The fifth one is to support meaningful connections to minimize isolation in cases where family is unable to be physically present using virtual or other means. Inform and educate in cases where family can be with their loved one physically, adopting a shared decision-making approach to communicate the risk and benefits. Enlist family as partners for quality and safety and engaging them as members of the care team who share in the responsibility for abiding by established safety protocols. And finally, enhancing discharge education and post-discharge follow-up to support successful transitions of care, especially when families have not been present during a hospitalization. I want to show you a video. And to do that, I have to stop sharing. So bear with me for a minute so that I can find the video. It is our Chief Patient Experience Officer, and it is in the guideline number 3, where you inform your families ahead of time about the restrictions you put in place. So I wanted to show you how we did that, and I'm hoping it works.
Hi, my name is Lisa Allen. I'm the Chief Patient Experience Officer for Johns Hopkins Medicine. We're witnessing a novel illness that is having a devastating impact on communities all over the world. Amidst this deadly virus, we still have people that need our specialized care. As a large health system, we have a responsibility to remain open and provide care to all who need it. We also have a responsibility to keep all of our patients safe and protected from harm.
So this video, like I said, was developed by our Service Excellence team for patients and families. To continue with the visitation guidelines, the health and safety of patients, families, and staff members is the top priority. Our care partner visitation guidelines balance preventing the spread of COVID-19 with the needs of our patients and their loved ones. A care partner can be a relative, a partner, friend, or anyone the patient chooses to have at their side. Johns Hopkins
Ms.
Medicine.
Burns,
Yes.
do you mind stop sharing and reshare again, please?
Okay. Can you see it now?
We could see you and hear you clearly. Please carry on.
Good. Okay. So Johns Hopkins Medicine evaluates our visitation risk levels every week and uses data that monitors the spread of COVID-19 in states and counties to help determine the level. For patients who need to stay overnight at the Johns Hopkins Medicine Hospital, we are using 4 color-coded visitation risk levels, as you can see on the slide, purple, red, yellow, and green, to determine if care partners may safely visit patients during their hospital stay. These levels are based primarily on COVID-19 activity in the community. Purple is the most limited level and green is the most open. In the critical or purple level, all care partners must request a visitor exception. All exceptions require review and approval before a care partner may arrive. 1 care partner is allowed per patient who has an approved exceptions, and exceptions are granted under the following circumstances. A patient with a disability who needs assistance, patients undergoing emergency surgery related to a traumatic event, patients with rehabilitation or cognitive needs whose care team has scheduled care partner training, patient and care partner discharge education when in-person bedside education is required. The red level is basically the same, but exceptions are granted for a couple more things like patients in the intensive care unit or intermediate care unit and patients who have been in the hospital for 3 days or more. Recently, we have made a change to the visitation policy because many staff emphasize the important and essential support that care partners provide for our patients. And although our care partner visitation risk was at purple or critical level, the Hopkins Hospital has modified its guidelines to allow a weekly visit from a care partner for some group of adult inpatients who have been on the unit for a week or more. Currently, our visitation is at the red level, and we're hoping with more and more people being vaccinated that we can lift some more of those restrictions. Visitors have to get a daily COVID-19 screening. Face masks are required, and they have to follow all physical distancing and hand hygiene guidelines. They cannot stay if they feel sick, if they have COVID-19 or flu-like symptoms, if they have tested positive for COVID-19 within the last 3 weeks, if they have been in contact with someone who has tested positive for COVID-19 within the last 2 weeks, or if they have been asked to be on home quarantine or isolations. Face masks are required to enter any of our care facilities and expected to be worn at all times. We will provide a face mask if that's necessary. You cannot wear neck gaiters, bandanas, or masks with exhalation valves. And you can remove your mask for eating and drinking, but you have to put it back on as soon as you are done. And if you are eating or drinking and a care team member enters the room, you must put your face mask on immediately. If a care partner needs to leave the hospital during their visitation, they may not return on the same day. And let's talk a little more about masks, because we all know how difficult it is to wear one all day, but also to have to interact with people who are wearing masks. So just be mindful to make a connection. Be the first to say, hello, good morning, how are you? Make and maintain eye contact when you are speaking. Make your voice heard, so speak plainly, slowly, and face the person to improve understanding. Make a positive statement about wearing the mask. I'm wearing this mask for your safety and for mine. Make your feelings known. Say that you're sorry that they're not feeling well and that you're there to help them. Make your caring felt by being more verbal and narrate your care. For example, when you come in, you can just say, hey, I'm here to change your IV now. It will only take a few minutes. The A is for acknowledging feelings. I understand it's challenging. This is a lot of information. Can you hear me well enough? Do I need to repeat anything for you? Ask questions. For example, what are your main concerns today? I want to make sure you have the chance to ask me questions. Use affirmations or use supportive words when talking, such as "you're doing great." The S is for smile. Smile behind your mask. It's important to smile. People can see it in your eyes and hear it in your tone of voice. Show your caring non-verbally by using good body language. Face the person you are talking to, uncross your arms, and demonstrate you are interested in what they are saying. Speak clearly again. Use a good volume, but don't yell from behind the mask. Be patient and kind in your response. Again, focus on the safety aspect on it. When faced with questions about why visitors are required to wear masks, acknowledge the question and explain how masks prevent spread of the virus. And then finally, the key points, use your communication skills. If you remember the heart, head, heart, you start with heart, speak from your heart first. Then you use your head, explain what you can do to help the situation, and then finish again with heart. Thank the person for sharing their concern. And finally, kindness matters, now more than ever. Demonstrate you are kind in all your actions and words. Convey emotional support for patient, visitors, and co-workers during these challenging times. And practice the present. Be patient and present in every interaction. Show your support for patient, visitors, and co-workers. So here are some pictures of the mask that we have seen. This one is especially helpful for the deaf community. When you wear a PAPR, your face is visible, so that's a little bit more helpful. And then we have all seen people who have printed out their own pictures and put them on their lab coats and uniforms so that the patients and families still see what you look like. To help connect patients with their loved ones, Hopkins has created a way for friends and families to share pictures with hospital patients through email. So simply email favorite photos to the Johns Hopkins Friendly Faces email address, and a staff member will print up to 8 photos per patient and deliver them to the patient's bedside. And the goal of the Friendly Faces is to help the Johns Hopkins community feel a little closer to the people and things they care about during this stressful time. Another way you can help your patients to stay in contact with their loved ones is using FaceTime, Zoom, Google Hangouts, or Skype. It's been used a lot in the hospital this last year. And finally, in summary, I would like to say that person-centered care, although it is a huge challenge, it is still possible during a pandemic, but it requires innovation, creativity, and resilience. And patients and families need a voice in their care. I think that is the most important. We need to realize that even though we have to balance the safety, it's still important that patients and families are included in the care they receive. I'm happy to answer any questions. Here's my email in case you have questions that are not answered today. These are the references I used.
Thank you, Ms. Brands, for the excellent presentation. I received no question from our audience, but I have a small comment here. We needed to help our patients and families as patient-centered or person-centered care, as well as our staff. And you shared excellent advice for the healthcare staff to maintain a positive relation with the patients and their families, and also among the inter-colleague relations. Is there any other measure or advice that you want to contribute by the end of your presentation?
I think what Dr. Wu also mentioned is very important especially for staff, to take time for yourself, to make sure that you stay healthy, because if you are not healthy, you cannot take care of anybody else. So take care of yourself, make sure you exercise, eat healthy, take time for yourself, but also advise that to the families of the patients that are very sick in your hospital. They also need to take care of themselves. Often they forget to take good care of themselves because they're so worried of the person who's in the hospital. But again, if they don't take care of themselves, they will not be able to take care of the patient once they come home. So I think that would be my advice.
Thank you so much for the advice. And now we will have to go to the last but not least presentation for this year's symposium, which will be delivered also from Baltimore by Dr. Lisa Maragakis. She's the Senior Director of Infection Prevention, Johns Hopkins Health System. Her presentation today is entitled COVID-19 Pandemic, Lessons Learned to Inform Preparations for Future Threats. Please join me in welcoming Dr. Maragakis.
Thank you so much. I hope everyone can hear me clearly. And I want to say again how honored I am to be invited to participate in this wonderful conference and summit. I hope everyone has learned a lot and that it will help to inform our actions working together to keep everyone safe going forward. I'm going to speak to you today in general about some lessons that we have learned from this pandemic and the pandemic response, and how this may inform preparations for future threats. Of course, we have to recognize that we are still embedded in the response. We are not yet out of the woods, and many more lessons will be learned, and there is a lot of work ahead of us in the coming months and years to ensure that we are better prepared for the next infectious disease threat. The objectives of my presentation are basically to outline some key lessons that we have learned and discuss how this will inform our work going forward. So I would like to begin by one of the major lessons that I think we have learned again and again throughout the history of our fight against infectious diseases, and that is the need for global cooperation and transparency and sharing. And this is more important now than ever before because of the global nature of our world, because of international travel and interconnectedness that means that our success or our failure in confronting infectious disease threats really relies on our ability to take a global perspective and to understand that we all rise or fall together, and that there is so much more that we can do when we cooperate and share. This has to do with every aspect of recognizing infectious disease threats, having early warning systems to understand the epidemiology of infectious disease threats, to share that information very rapidly around the world, and initiate very rapid scientific collaborations and sharing of information that recognizes our interconnectedness and allows us to respond as a global community and to do things that are very difficult, if not impossible, to accomplish in isolation. Now, of course, this is important even from the very earliest times when an infectious threat emerges, so that we can all recognize it, help to identify the pathogen, to provide data and track the epidemiology of the organism, and also for scientific discovery, which we'll talk about a little bit more during the presentation. But it is also very, very important for the response itself. And we find ourselves now in the vaccination phase of the global response to COVID-19. And now, as always, we need to take this global perspective and to understand that even though vaccine remains in somewhat limited supply, and there is great variation across the world in the supply of vaccines, that again, we need to come together and ensure that vaccines are available and administered worldwide because this will suppress the viral transmission and limit the virus's ability to continue to mutate and develop variations and strains that could pose future threats, even from this virus, to the rest of us as part of the global community. So I put this as the #1 lesson: global cooperation, sharing, and collaboration. So I mentioned variants and the importance of limiting the spread of the virus so that we can stop the virus's opportunities for mutation. We have seen many variants already spreading around the world, including most notably the B.1.1.7 variant that arose initially, or first was identified in the United Kingdom, the B.1.351 that was first identified in South Africa, the P.1 variant that was identified in Brazil, but we have had other variants in New York, in California, and really around the world. And what we are seeing is convergent evolution, so that for many months, we did not detect, as a worldwide community, significant mutation in this virus of any concern. But what we know is that it is an RNA virus, and RNA viruses mutate quite rapidly and often. Many of those mutations do not lead to any significant change in the function of the virus, and those strains fall away. But what we are seeing now in all of these different variants is that certain mutations are arising in the spike protein in particular that are very advantageous to the virus and lead to higher viral loads in the upper airways, to more transmission person to person so that the virus is more easily transmitted, and in some cases more severe disease. So this is a serious threat. We are in the race with the virus, and the more we can suppress its opportunity to replicate itself and further mutate, the better off we will be. The convergent evolution is really showing that these variants that carry these certain advantageous mutations are arising independently in different parts of the world. And that's how we know that they are truly advantageous to this virus, because we're detecting them and they're spreading. So this is a truly urgent issue and a new phase of the threat of the pandemic. Again, I go back to that theme of global cooperation so that we have surveillance, we understand where these variants are, and we take a global approach to stopping the transmission of all of the variants. Surveillance, of course, is very important in epidemiology and infectious disease, whether we are looking for new pathogens or in this case, we are looking for variants. And so again, along with the vaccination efforts globally, we need surveillance for the variants. This brings me to another lesson that we have learned during the COVID-19 response, and one that we will need to carry forward in the future, and that is the value, the extreme value of real-time data. Bringing together data, not just of the local situations, because those are very important, of course, for local response, but really of worldwide data. On this slide, you see one example of such a data dashboard. We are very grateful to our colleagues in the Johns Hopkins University Center for Systems Science and Engineering who developed this platform, which really was spread around the world from the earliest months of the pandemic and allows visualization of so much information that these researchers were able to pull from the primary data sources and to collate into one worldwide dashboard to be able to track the number of cases, the number of deaths, and they have continued to improve the dashboard so that it brings in vaccinations and other critical trends so that this is like looking out of the windshield if you're driving a car, so that we can see down the road, we can see behind us, we know where we are and what we must do. So the value of real-time data cannot be overstated. I think this also brings back the theme of global cooperation, because we have seen lots of disagreements, arguments over definitions, how things are counted, even how cases are counted, how deaths are counted. And so this also is an area in which global cooperation, standardization of the data elements, how they are defined, how they are shared, is also another opportunity. And of course, you know, the data that I'm showing you right now are in the midst of a pandemic response that we have been fighting for a year. But the value of real-time data is also important for that early detection piece, so that we have surveillance for new emerging pathogens and understand when things are beginning to get out of control so that steps can be taken. Of course, many of these lessons have been learned in prior outbreaks, but the better we get at assimilating and sharing data, the better off we will be. Another lesson I would like to discuss with you this afternoon is that history repeats itself, and there are parallels. So our own experience in this pandemic is a very powerful lesson, and we will be examining it, learning from it, and taking steps differently in the future for probably the rest of our lives, because what we have experienced during this challenge. However, when we study the previous history of pandemics, this can also be extremely informative and can help us see where we have failed in the past, perhaps, to learn lessons and to adequately prepare ourselves. So on the screen, you see a picture of one book. There are many accounts of the 1918 influenza pandemic that swept around the world. This particular one is called Pale Rider. It is written by Laura Spinney. I highly recommend it if you've not read it or another account of the 1918 influenza pandemic. I recently read this book, and it was very striking to me, the parallels between what the world experienced in 1918 and what we are now experiencing in 2019 and 2020, and now 2021. So I won't belabor all of the parallels, but just point to the fact that we must learn from the past and the present to better prepare and avoid the same pitfalls in the future. Some of the striking things to me about reading this book and thinking about the 1918 influenza pandemic is that in 100 years, science has advanced greatly. In 1918, no one knew what a virus was. So they faced a pandemic without even understanding the agent of the disease, the pathogen that caused the disease. They did not have the opportunities we have now to name that virus, to understand its transmission dynamics, to develop therapeutics and vaccines the way we have for this one. And yet, nonetheless, as a global community, they suffered much in the same way that we have in this pandemic. And so I think we do need to ask ourselves, once we are out of this, how we can better apply the scientific knowledge that we have gained. And in particular, and this will come in a moment when I continue outlining the lessons from this pandemic, but in particular, science is a very powerful tool, but there are also very powerful social and economic and religious and political factors that come to play when the global community is facing a pandemic like this. And we need to understand that so that we can better prepare ourselves to address those aspects of a pandemic response alongside the scientific discoveries. The 1918 influenza pandemic, for instance, occurred sandwiched between World War I and World War II. And we can only imagine now, looking back, how that influenced the worldwide reaction to a sweeping pandemic of influenza that killed actually many more people than died in both of those wars combined. Moving on to another lesson that is important for us to ponder and address as we go forward is the issue of disparities and inequalities in the risk of serious disease, serious disease and death. And this is a phenomenon that has occurred around the world. I have on this slide some data from the United States. On the left-hand side is a graph from the Centers for Disease Control and Prevention that outlines some of the disparities in the early part of the pandemic last spring amongst different racial and ethnic groups in the United States, age-adjusted hospitalization rates by race and ethnicity. And we see dramatic differences between non-Hispanic American Indians and Alaska Natives, non-Hispanic Black individuals, Hispanic and Latinos who had much higher hospitalization rates at that time than the non-Hispanic Asian or Pacific Islanders and the non-Hispanic whites. This could be an entire talk, but there are many reasons why these patterns emerge, but we see it whether we look at case rates, whether we look at hospitalization rates, whether we look at mortality. And on the right side, you see disparities in the United States. And this is more recent data from this year, showing death rates by race and ethnicity per 100,000 residents. So again, I'm not focusing specifically on these data, but just to say that worldwide, we know that the pandemic has exacerbated underlying inequalities and disparities in health outcomes, access to healthcare, and many of these risk factors are tied to housing conditions, to economic conditions, access to healthcare, underlying medical conditions that already may reflect the disparity in higher rates of comorbidities and risk factors for severe disease or death. And then also the jobs that we know that when societies go into lockdown, certain individuals are more able than others to work from home and to avoid risks, while many populations, particularly in the lower socioeconomic levels of our societies, must continue encountering the public and are at higher risk. So again, this is not a new problem. This is a problem that the pandemic has really highlighted, and one that we must address, because to go back to the earlier theme, public health is a group activity. It is a global activity. And when the virus or any pathogen is spreading amongst any population in the world, that poses risk to everyone, not just to that population. Another lesson that I would like to emphasize is that leadership matters. And hopefully you are beginning to see from my comments today and from your own experience how some of the pandemic response can go awry if these various forces are pulling public policy or individual behavior in one direction or another. And so leadership matters. This is a time when the entire world is facing a challenge and everyone has fear and anxiety. Many people, are suffering greatly, not just from the infection, but from the effects of the lockdowns, economic fallout, so many different factors, mental health issues, so many things we've talked about during this Patient Safety Summit. And so where do we turn? We turn to our leaders, and it matters that we have leaders who can calmly and in a trustworthy fashion, describe what is happening and show a path towards taking productive steps to limit the transmission of the virus, to protect ourselves. And this is not an easy task. We have to build trust and credibility. And this really starts by expressing empathy and caring. It's very difficult to trust someone if you don't feel that they care for you. So empathy and caring goes hand in hand with scientific competence and expertise, honesty and openness, and commitment and dedication. And we see this type of leadership at the institutional level, at the local level, at national levels, and worldwide. So we need to think about the infrastructure and developing the leaders and building the credibility and trust over time in between infectious disease threats, so that people know to whom they can turn and who they can trust and listen to when it really matters. I'd like to share with you another book, a recommended book, and that is The Practice of Adaptive Leadership, that was written in 2009, and has some very important lessons, I think, for leadership, particularly in crises situations. And I've listed on this slide some of the lessons, just a big picture summary of some of the lessons in this book about adaptive leadership that help us keep the big picture in mind, to understand that everyone is really having distress of various kinds during the pandemic, and that part of a leader's job is to regulate others' distress, providing information that sometimes is not good and could be frightening information about the pandemic. So in such a way that we don't overwhelm people, but we keep enough tension to urge them towards the behaviors that will help protect them. We need to challenge norms and ask questions rather than just talking at people. Maintain our focus, resist all of the various distractions that come, and help to really reframe issues and describe the narrative so that we can guide the conversation and encourage others to assume responsibility for their actions. Always providing support and encouragement to the team that is doing the difficult work. We've heard a lot about that in this conference. And then finally, really protecting and hearing all voices, even those that sound like dissent, because this is an enormous problem, and an enormous problem demands enormous answers. And there's so many aspects to it that one person has difficulty understanding all of those components without really listening carefully. On the theme of leadership, I wanted to include discussion today the benefits of an incident command system or structure for responding to pandemic threats, to infectious disease threats, and many other kinds of natural disasters and other situations. The incident command system is often used by emergency managers, and is more commonly thought of, I think, in response to natural disasters that are of a more time-limited nature. Think of an earthquake hitting an area and an emergency management response, for instance. The incident command system fosters cooperation between the different disciplines that must come together to confront any kind of challenge. It helps foster communication by having common terminology and a very systematic planning process. This incident command system uses the chain of command that helps clarify roles and responsibilities so that everyone understands what their role in the response is and is coordinated, the use of resources and individuals. And so if you have not participated in an incident command response, I encourage you to learn more about it and to think about how it can be used at the local and at every level, really, of the response, so that there is a coordinated manner in which the planning and assessment of the response occurs. You see a picture on the screen of our incident command center in the early days of the pandemic before we were wearing masks, but it incorporates some of the features that I'm discussing today, including the use of data and leadership and this incident command structure, which is very, very beneficial. Another thing about this, however, is that it requires preparation. And so if we adopt this as a way to respond to infectious disease threats, we need to continue laying the groundwork in between infectious disease threats so that we have the infrastructure and the training to know, so that individuals know how this works and can more easily come together into an incident command structure and use it to our advantage. Turning to yet another lesson that I wanted to highlight, and this is perhaps one of the main lessons that I have learned during this pandemic and with which we have struggled and continue to struggle, and that is that our global supply chains are much more fragile and tenuous than we ever knew, certainly than I ever knew. It was shocking. It continues to be shocking that we need to face an infectious disease pathogen without adequate personal protective equipment, hand sanitizer, disinfectants. The list is endless. And the shortages worldwide have gone on for many months and now more than a year. It is better now, but there is great unevenness in availability of critical supplies. And I am only showing on this slide some of the challenges that we faced in healthcare about personal protective equipment, disinfectant, sanitizer, hand sanitizer, but it goes even much more broadly in medicine to include pharmaceutical treatments, of course, vaccine now, but also needles and syringes. Testing supplies and reagents were in short supply for so long, even swabs to collect the sample. And so it was really quite shocking, I think, as a modern global society to have the greatest advances in PCR testing for a pathogen and the most rapid identification of the virus and development of a test. And yet we didn't have swabs at one point to collect the samples and had to limit that resource. So this is work that we must do as a global community going forward to really critically think about how our supply chains are set up and how we can improve our resilience as a world to get the supplies that are needed into the hands of those who need them to prevent the virus from spreading more broadly and having an opportunity to mutate. This is a related concept, very different, I guess, than the supply chain one that I just discussed. But we have had many sessions before this pandemic planning for pandemic respiratory virus. And in most of those sessions, we talk about respirators as being the most critical piece of equipment or resource that might be in short supply and need to be allocated, and many agonizing ethical discussions about how one could allocate scarce respirators fairly to those who need it if you had more people who needed a respirator than you had respirators. And that, I'm not minimizing that issue. That is an incredibly important issue. But here we are in the midst of a global pandemic, and what have we seen more often than a shortage of respirators is a shortage of staffing. So people, our human resource, expertise in physicians, in nurses, in respiratory therapists, in all of the different critical roles within healthcare, it was really the main challenge and continues to be the main challenge in areas that are still seeing surges. And I think each of our facilities has faced this trouble with critical staffing levels being the scarce resource that limits our ability to further increase the number of patients for whom we can care during the pandemic response. So a lot of work lies ahead of us to think about how we can build more resilience into our staffing structures and be more prepared to get the people and the expertise where they need to be to expand capacity as surges of a pathogen occur in different geographic locations.
We are running short on time, Dr. Maragakis.
Okay. Would you like for me to just quickly finish, or do we need to end now?
Finish in 2 minutes, please. I have
Okay.
one interaction with you later.
Okay, that sounds fine. So I'm almost finished. So basically strong, I've mentioned this, but strong social, economic, political, and other forces fight against our evidence-based infection prevention. And so science is not enough. We need to work with other disciplines who understand these forces of political and social factors that can limit the effectiveness of our response. And as I've said, public health is a group activity that requires cooperation, understanding, patience, empathy, and finally, just preparedness and resources of infrastructure before there is a crisis. So this is the work ahead of us to make sure that public health has the resources that we need to make the preparations so we can do all of the things that I have discussed today. And then, of course, we understand the power of science and global cooperation here and the miracles that it has brought about, that we have a vaccine in hand, more than one vaccine in hand. And so this will be important to continue, of course, in hand with the other things we've discussed today. And then I will finish by saying that infection prevention works. The very basic measures of distancing, masking, and all the other things we've discussed during this conference have helped essentially eliminate influenza this year. So please remember that they work, and we have lessons learned and a need to think about that in future respiratory virus season. What will we incorporate going forward, even once we're out of the pandemic? And we will also consider the new ways of working and how those might apply to limit the damage from respiratory diseases. And of course, everyone during the conference has talked about the need to support each other. And safety officers was one big lesson that we learned to improve safety during healthcare's pandemic response. So I'll stop here with my take-home messages of cooperation, preparation, learning from the past and the present, caring for ourselves and each other. And please, please, we are still in a race with the virus, so we need to interrupt viral transmission and continue infection prevention while we vaccinate everyone as soon as possible. Thank you.
Thank you, Dr. Maragakis, for the great presentation as usual. As you know that there are two sides for everything. For this disaster, we have the difficult side and also the green side. We got better on communication globally, and we have enhanced systems, more information, we're more available to the public, as well as the staff working in the healthcare system. Do you envision any better global preparedness for any future disaster? We probably spoke about this yesterday, but it wouldn't hurt if you repeat on it. Thank you.
Absolutely, yes. You know, I've said many of these lessons learned as recognizing challenges and places where maybe we didn't do as well as we would wish. But there is, as you say, the other side of it, that many accomplishments and triumphs. And one of them that we have to tout the most is the development of not just one, but many vaccines that are safe and effective and in record time, 1 year. So I think that we see over history, the global community learning to cooperate, to work together, and to pull off true miracles of science.
All right, thank you very much, Dr. Maragakis, for the presentation. It's the end of our day, and we will be back again here in Dhahran. Tagreed will have announcement here.
And now we would like to invite Dr. Michael Walsh, Chief Executive Officers, and Dr. Saeed Al-Yami, Chief Quality and Patient Safety Officer, to the stage for a recognition session and closing remarks. Also, Dr. Masloom will announce the winner of the posters.
Okay, first of all, I would like to take this opportunity to thank all the poster participants and salute them for the good job everyone put in his hard work. Also, would like to thank all the people from our audience who participated in the voting process. We received a great number of votes for our 8 posters. And now it's time to announce the winners. I'll start with the 3rd winner, which is poster with the designation letter C, under the title of Learning from Defect, an engaging educational journey towards patient safety, quality, oxygen therapy, and safety at Johns Hopkins Aramco Healthcare Center in Saudi Arabia. Congratulations for Fatima Abdul Jabbar and her team.
Fatma here?
Is Fatima around? Come up.
Okay. There we are. Don't smile, mask does not help it, but
The eyes will show.
smiling with our eyes. Thank you very much. Thank you for the work. Thank you.
Good job, Fatima. The second winner is poster with the designation letter E. Title, Patient-Centric Medication Management System to improve patient safety and optimize services at Johns Hopkins Aramco Healthcare, Saudi Arabia. Congratulations for Mr. Habib Nimr and his team. Congratulations, Habib. And finally, the first winner is poster with the designation letter B. Title, Cost Effectiveness and Outcomes of Early or Same-Day Discharge after Elective Percutaneous Coronary Interventions in Heart and Vascular Institute at Johns Hopkins Aramco Healthcare. Congratulations for Dr. Ali Shihri and Ms. Sahar Al-Agul, who is representing him.
Vida is with them?
Is Vida around as well? I don't see her.
Okay. Eventually, yes, I'm very happy. Good job. Thank you very much.
Congratulations for the Heart. Congratulations for the Heart and Vascular Institute. Let's go now with
And
Taqreed.
leave it now for Dr. Walsh for the closing remarks. Please, Doctor.
Good afternoon, everyone, and thank you for the opportunity to briefly meet with you now to offer some closing remarks. Firstly, I would like to thank all the presenters, all those who put in posters and participated so actively in the symposium. The content has been excellent and enthusiastically attended by well over 1,000 attendees over the course of the 2-day symposium. So I want to thank all of you who have participated, and of course I want to thank those who have done the organisation to enable this symposium to take place. We do live in a different world now where we are able to conduct these symposiums virtually. It has pluses and minuses, I guess. Those who are old like me used to actually quite enjoy going to conferences and meeting up with colleagues and old friends that you had dealt with over the years. So part of us, I guess, misses the in-person nature of such professional conferences. But on the other hand, the convenience and accessibility of conferences like the one that you've done such an excellent job of putting on, I think helps make up for that vacuum, that professional isolation that perhaps some of the COVID restrictions have enforced upon us over the last 12 to 18 months. So thank you very much to the organisers. And of course, in respect of the content, very important topics of discussion, and we've heard some great insights, I think, over the course of the 2-day symposium. So I think it's only fitting to acknowledge that we've all learned something from the last couple of days, and various things will stay with us over the coming weeks and months and years as we continue on. I think there's no doubt in anyone's mind really that the ramifications of COVID and the way that we've responded to it is likely to be with us for some considerable time yet. And so it's great to have been able to collect these insights at this stage. So thank you all, well done, and I look forward to the next symposium. Thank you.
Thank you, thank you. As we started yesterday, as usual, you did a great job. I want to second Dr. Walsh with the effort was done. There was great speakers, great posters, and people who did not win. I think you did an amazing job. So thank you for your contribution. And officially, I'm announcing the cessation of this symposium. Thank you very much. Thank you.